Mic check. Mic check.
So they should have, yeah. Yes, sir. Throw things at me from the back. You cleaning it out? Oh, thank you. You still let you let the hand organized. You let the hand go. Yes, sir. Okay, all right. You never know what you need to. How's your dad doing? Any movement on that thing we talked about? Yeah, he'll be popular guy. That's fine. Oh, she wrote you wrote her. Oh, I get anything? Okay. Do you have slides? Okay. Good morning. We'll go ahead and start making our way to our seats. We'll get the conference started. First of all, I'd like to welcome you to our second Readiness project being hosted by NYIT, College of Osteopathic Medicine at Arkansas State University, with gracious support from Blue Cross Blue Shield. I don't know how many of you had to show up today in a canoe with paddles or a life raft. We do have extra life preservers in the back, so if any of you need help getting home, we can help facilitate that. I do know that several of you made quite a trip from certain parts of the state, and we do appreciate the journey you've made to come help support us in this endeavor. If you've had a look, taken a look at our agenda, you'll see that we have several well-known speakers, many nationally known speakers for the conference today and tomorrow. We're looking forward to hearing the information they'll be bringing forth regarding population health because of the significance it has, particularly on the state of Arkansas and this region of the nation. So I know I'm excited about hearing many of the lecturers as we move forward. Our first lecturer today is someone that I know very well now, Dr. Barbara Ross-Lee. Dr. Ross-Lee is the Vice President of Health Sciences and Medical Affairs and is the founding dean for the New York Institute of Technology's College of Osteopathic Medicine at Arkansas State University. Dr. Ross-Lee is a nationally recognized expert on health policy issues and serves as an advisor on primary care, medical education, minority health, women's health, and rural health care issues on the federal and state levels. She's the director of the American Osteopathic Association's Health Policy Fellowship Program, which prepares mid-career osteopathic physicians, such as myself, for leadership roles in health policy. She's also the director of the Training in Policy Studies, which is a program set up for osteopathic resident physicians that train those physicians in policy issues at the graduate level. She's the director of the Institute of National Health Policy and Research and a member of the Executive Committee of the National Osteopathic Medical Association, which is a medical association for minority osteopathic physicians. Dr. Ross-Lee is the first African American woman to serve as Dean of the United States Medical School. She also served as the first osteopathic physician to participate in the Robert Wood Johnson Health Policy Fellowship. Dr. Ross-Lee served as a commissioned officer in the United States Naval Reserve's Medical Corps, achieving the rank of captain. She has lectured widely and published numerous scholarly articles, on a variety of medical and healthcare issues. She has received 6 honorary degrees and many national awards. It is with great pleasure that I ask you to join me in welcoming Dr. Ross Lee to the stage.
Thank you, Shane, for that great introduction. It's longer than my presentation. Well, let's say good morning and join Shane in welcoming all of you to our second Medical Education Readiness program. And we welcome you as partners in this endeavor because it's important and that we all understand that we are together. This is a collaborative project. None of us can do it alone. As you know now, my name is Barbara Ross Lee, but if you don't know, I'm wearing a lot of tags, okay, so that you can see who I am. And I have the honor of serving as the Dean of the NYIT College of Osteopathic Medicine at Arkansas State University. While it takes a village to raise a child, it definitely takes a healthcare community to produce physicians. So I just want to answer a few questions today and kind of give you an overview of why you will be hearing these topics today and tomorrow and how they relate to our educational mission. First question is, why are we here? And, you know, I don't need to tell you, because I think you all know what the health status is in Arkansas. But I will go through a couple of very brief points. The health status of the population of Arkansas is ranked second worst of the 50 states. The physician workforce shortage in Arkansas is ranked 47 or 48 of all 50 states. And of course that depends on what day you look at the data and who's doing the reporting. But we haven't risen to 45. And third, working together, in less than 5 years, we will be producing over 100 graduated physicians each year. It's working together. And so we can turn those numbers, that shortage, we can turn it around. But we have to do it together. So I thank all of you for demonstrating your commitment to medical education by being here and sharing the vision to educate physicians in Arkansas for Arkansas. We share the awesome responsibility to prepare the physicians of the future, which means we have to educate our students not for the way medicine is practiced today, but ultimately be able to look around corners and watch the evolution of healthcare and population needs, and be able to educate competent physicians who will serve in the future. So how are we going to do that? First of all, we're going to align the education with the evolving health needs of the populations these future physicians will serve. And let's remember that word. It's alignment with needs. Second, we're going to use a model of medical education that's a departure from the 100-year-old flexnerian model. We're going to use a model of medical education that partners with health institutions in the communities. So let me just give you an update of where we are today. Our first class of 115 students will begin August 8th of this year. This represents, for me, less than 3 years since my first visit to Arkansas. And I think we can all be proud of the rapid process that we have made, our rapid progress that we have made to get to this point today. Because we did it together. Nobody did it alone. We use a rolling admissions process, and currently we have 106, it was 104, and I just talked to our admissions office. So we have 106 students who have been accepted and have committed for this new class that starts in August. That's out of 115, which is the class size. I'm sorry? I thought I heard something. For those who are always curious, and I get this question all the time, what's the grade point in the MCAT scores of these students? I want you to know that of the 106 students that are committed, we are exceeding or above the national average, osteopathic average, for medical students. So we're really proud that given, 6, 8, 10 weeks of recruiting, we have a strong class that will start in August. And we also want you to know that, let's see, about a third of our committed and admitted students are from Arkansas. The balance, 2/3 of these students, are from our targeted region. So let me just tell you what that targeted region is. Our targeted region includes Arkansas as a priority, Missouri, Illinois, Texas, Tennessee, Mississippi, Louisiana, Alabama, and Florida. And for all of those people who were afraid that we were going to be admitting New York students down here in Arkansas, we don't happen to have a New York student in this class, and I just want you to know that. I also want to let you know, for those of you who are very familiar with Bay State, Wilson Hall, which will house the medical school, will be ready mid-May. And we're really excited about that because in mid-May we will all finally have a permanent home here in Arkansas, on the campus of Arkansas State. So, needless to say, we are getting ready. And that includes all of you. Although many of you will not see your first students until the summer of 2018, I guarantee you that these next 2 years will go by really quickly. But you and we will be ready. I want to take this opportunity to thank Blue Cross Blue Shield of Arkansas for their support, which has made this Readiness project possible. And I also want to thank a special thank to Chancellor Tim Hudson, who, from my perspective, just 3 short years ago, it was his vision that led us here and that got us here today. He had significant support from the president of the A-State system, Chuck Welch, but he also had the commitment and support of the entire community, which was so exciting to see on my first visit to Arkansas. So, now I would like to invite my second in command, who will moderate this program for us, to come to the podium, and we can get started with all of the really good information that you're going to receive today. Okay, Dr. Spice.
Thank you, Dr. Ross Lee. We will start off this morning with 2 fine guests from Ohio. We have 3 fine guests from Ohio, and 2 of them will start this morning with Dr. Jane Hamill-Lambert and Dr. Sebastian Diaz. Dr. Hamill-Lambert joined the Nationwide Children's Hospital Child Development Center in Ohio State, the Department of Pediatrics, in 2016. Prior to that, Dr. Hamill-Lambert was an associate professor at Ohio University's Heritage College of Osteopathic Medicine. In her tenure at Ohio University, Dr. Hamill-Lambert advanced the Campus Community Engagement Initiative, focusing on improving the child health delivery system across the Appalachian counties in southeastern Ohio. Early on, this effort focused on developing equitable partnerships and the establishment of a regional nonprofit organization through which to advance rural health initiatives. Most recently, she introduced pay-for-performance contracting opportunities that target improving maternal and child health outcomes through a regional, community-based, care-coordinated effort. Dr. Hamill-Lambert earned a doctorate in clinical psychology in 1990 from Ohio University and a master's in business administration from Case Western Reserve University in 2001. Her clinical area of expertise is in pediatric psychology, and other interests include leadership, collaborative partnerships, and community-based participatory methodologies. Prior to working at Ohio University, she worked at the Cleveland Clinic Foundation and Rainbow Babies and Children's Hospital as faculty at Case Western Reserve University. Dr. Sebastian Diaz currently serves as an associate professor of family medicine at the Ohio University Heritage College of Osteopathic Medicine. In his role as the research lead for the Central Appalachian Consortium of Colleges of Osteopathic Medicine, his HCOM colleagues and his partner with Kentucky College of Osteopathic Medicine and the DeBusk College of Osteopathic Medicine, that's a lot of medical schools, to investigate how health outcomes can be improved in Central Appalachia. Through his research, writing, and consulting work, Sebastian continues to explore how the principles of knowledge management can be leveraged within the academy by educating partners. He earned degrees from Marietta College, a BS in chemistry, from Ohio University, where he earned his PhD in educational research and evaluation, and the University of Akron School of Law, where he earned his law degree. Sebastian and his wife Andrea live with their 2 daughters on a small farm in Brandonville, West Virginia. Please join me in welcoming to the stage Dr. Jane Hamill-Lambert and Dr. Sebastian Diaz.
Good morning to everybody. I am going to, Sebastian and I are going to tag team a couple parts of your agenda today, this morning's conversation and then a workshop this afternoon. So I'll take the lead for this piece and he'll take the lead in the afternoon. But really we're both sort of on the mic, even though I'm the one standing up here. Thank you very much for the thoughtful introduction and for inviting me to be here today. I was really excited to hear about this meeting because I think it represents something that doesn't happen enough. You could tell from, I think, from my opening introduction that I am a professional who has really worked hard to join with communities to make a difference. And so I'm a pediatric psychologist. I've been in Southeast Ohio. It's a very rural community. Although Ohio has some health outcomes that look better nationally than maybe Arkansas, when you really get into place-based statistics, things look very different. And so there was a lot of work to do in Southeast Ohio, and I was of the opinion we couldn't do it without the community. And so this is what I would call a multi-stakeholder meeting. And I think it's very generous of Blue Cross and Blue Shield to fund it, and very insightful of the folks here at Arkansas State, the folks from NYIT, and the health delivery system representation that we have in the audience today, to create the space not just to have a meeting, but to really have a series of meetings that gives you an opportunity to get to know each other and to think about sort of what are the resources that each of you has in your back pocket that can contribute to an agenda that I think is not just about physician education, but really about educating physicians with an eye towards the impact of that initiative on the health of a community. And this kind of get together and start to think and design things from the get-go, there's just not enough of this that happens. I open up our conversation this morning with this slide, with particularly to an eye to the hospital systems who, as Barbara noted, are waiting 2 years before they see a student. But it's really the practice environment, and there's I think the majority of you in the audience are physicians, and many are practicing physicians, where med students and early career health professionals sort of imprint an attitude and beliefs about what the system is. And so this quote is from the Institute of Medicine, and this is a quote that's quite recent, that it calls for exactly what you folks are doing. It's calling for the people who are on the health education side to get together with the health service side and to do so with the policy eye on the conversation. So I think that this is just a really unique day and a really unique opportunity. So I applaud you for doing that. I then nag Massachusetts at heart. Don't just sit in a bunch of meetings and plan. Make sure you get around to doing something. And there's a lot you can start doing today, even as students are matriculating into the program, to set the stage so that when they get into the practice environment, the attitudes and beliefs you have are the ones that you can acculturate when they come to work with you. So the conversation is diverse, and I'm sitting in a pretty intense spotlight, and I tried to meet a few people before I took the stage, but I'd like to get a handle on really who we have, how many different voices we have in the audience. So I know we got Arkansas State folks. Can I see some hands? And I know we have NYIT folks. And all right, and then we've got a few delivery systems, which I think one is called NEA, and one is called St. Bernard's. And we have some folks from Blue Cross Blue Shield. Excellent. They're clustered. They live on an island back there. We have a handful of people from Ohio. There you go. And who did I miss? Who didn't I connect with? And where are you from, sir?
Doctors in practice.
Doctors in practice in... Okay, all right. And it sounds like most of the delivery system folks have a Craighead County presence, but also a regional presence and a multi-state presence. Is that the right landscape? All right, okay. They're where from here?
Three representatives.
From Little Rock?
Yeah.
All right, Little Rock folks. Okay, so I have a deck of slides, and I have 2 hours of time, and this is going to be most useful and relevant if people raise a hand, walk to a mic, interrupt, say, no, that's not how we think about it here. It's a framework for a conversation, and I encourage you to not let it become a didactic, Jane just talks at the mic morning. So please take that to heart and share your thoughts as you're having them. I think it's a nice sized audience to be interacting through this conversation. So one of the first things we want to do, and Sebastian helped set this up, is we built an online survey, and everybody's got a password, and everybody can get on their phones, many of you already are on your phones, and go fill out the survey. And the survey is about knowledge, attitudes, and beliefs about population health. And so one conversation we want to have with you today is really about thinking through how much data we generate and how to use the data that is created. All of you who are on electronic health records do this all day, every day. The people who are going to be responsible for the admissions and the applications and the grading and the placements and of the students, there's a wealth of data in those environments as well. And so just to sort of think a little bit about kind of how data is generated and how data is used, we invite you to take the survey. We're going to receive it. Sebastian's down there live with his laptop, and we're going to feed it back to you, hopefully at the halfway point. So it will be obvious if you did or didn't fill out the survey, not as an individual, but just by our numbers. So if you just take 5 minutes, and we might need to lean on tech people for people to get on, but can people get into that survey? Excellent. I think it's 15 items. Possibly can't take longer than 6-7 minutes. Anyone stuck? We have lots of IT people dotting the landscape here. I've done enough teaching to know there's a few of you who are thinking you don't need to do this. Change your minds, change your minds. It's a short URL. We tried to shorten it up so it would be easily typed. Welcome. We're all taking a little survey. You just type in the URL into your device and up comes 15 questions about population health.
We have 4 responses.
I see diligent readers. If there's anybody who needs to borrow a device from your neighbor, I'm sure they'd loan. All right. How's the response rate looking? Okay. Let me just get a show of hands as to who's through it. Okay. And those who aren't waving, we'll give it a couple more minutes. All right. Thank you for cooperating. We're hoping the results teach ourselves a little bit about people's beliefs and attitudes about population health as you move into the partnerships you're creating. So my plan today is to sort of challenge what people think of as the idea of population health and to differentiate it from a conversation that far precedes it, which is public health, and to consider how it nests within constructs like the triple aim and sort of where it fits in the national rhetoric. And all of the population health conversation is linked to outcome data and population health data. And so from there, I want to walk into your community a little bit, which is much more of an exercise of discovery for me, probably, than it will be for you, but to think about how the data creates an understanding and sort of an inefficient or an insufficient knowledge base from which you need to work. And so how do you go from national data points down into community levels, understanding and move things forward for community and improve population health? At the end of that section, we should be at about the halfway mark if my pace and timing goes well. And so we're going to actually move up the break so you don't have to sit still for 2 hours. Take a little bit of a break and come back and talk about innovation. I'm going to spend a little bit of time talking about the project I'm attached to in Southeast Ohio, which was focused on improving the child health delivery system, and this particular section will be about our effort to improve low birth weight incidence in Ohio. And then really bring us back full circle to the idea that we're really here about physician health education. And if the ideas that we move through really need to find a place in education, how do we do that? Really what needs to be in a curriculum at the undergrad side of the education, and what needs to be in the practice environment to reinforce those ideas. So that's the big picture. Again, I encourage people to stand up, wave a hand, walk to a mic, and share your thoughts, because I think that'll make the day the richest. All right, so here is what I would assert is the definition of population health. Not that you can't find 300 of them if you Google it, but this one goes back to 2003, which in and of itself, I think, takes pause, because we have been talking about this for over a decade. And it is just really settling in to conversations like this. If we're going to build a med school and our agenda is really going to be about improving the health status of the communities we're within, how do we have to think moving forward to plan to do that so that it works? And so this definition, I think, is really worth understanding. And so it says that population health is more than just the health outcome, and that you're moving from looking at outcomes to considering the distribution of those outcomes. And certainly any of you in the delivery system side or the payer side of the conversation is acutely aware of the fact that you can have smaller units, smaller populations, zip codes, census tracts, where your data looks markedly different, and be within a stone's throw away from another census tract or a zip code. And so that's the distribution of the outcome issue. And so the next thing population health does for us is it says, so you have an outcome, you got to look close at the distribution, then you have to consider the factors or the determinants that are informing that distribution. And these are the conversations healthcare is in all the time. You know, why do those differences exist? And then once you get to thoughts on why the differences exist, then you're into policies and programs. So given the outcome and the way it distributes, our understanding of what's driving those differences, what do our policies and programs do to reinforce those disparities or redress those disparities? And that's population health. And so the factors really become the driver of the interventions, because the outcome itself is the end measure, right? So you get the outcome and you see the distribution of the outcome, but when you look closer, you start to go, well, what's that about? And we all have a bunch of knee-jerk reactions in rural communities. The most common where I live is this: people don't have transportation. And the distance between where I live and where I got to go get care is too great. And then we do health literacy. People don't understand what you tell them to do. And then we do access. Well, the specialist they need is only available if you drive 3 hours to the tertiary care center. And those are not irrelevant to any conversation about determinants, but those don't really get into the local knowledge community understanding of things. And so in Ohio, we had a huge transportation problem. Well, we had a transportation problem that when Mrs. Smith called and needed her ride to her appointment tomorrow, the policies that governed how you got that ride said you needed to call 72 hours in advance. That wasn't going to work for tomorrow's appointment. you needed to have only the patient who would be receiving the care in the vehicle that was transporting the patient. Well, that wasn't going to work for the single mother of 2 children under the age of 5. And then from there, and we literally had this happen with a woman we were trying to take care of. Somebody said, well, what's your street address? And in rural Southeast Ohio, unbeknownst to the person on the phone line, she really didn't have a street address. Sure, in some post office category she had a street address, but her definition of where she lived was, you know where the church was that burned down in I think it was 2010? Well, if you go, it's the second left after that, and just when you go through the dip in the road, and you know, I'm not the trailer next on the right, but we sit behind their land because it's my mother's second sister's wife, and if you go down the back driveway, you get to where I live. And the person on the phone said, well, but what's your address? You know, we can't send a driver to your house unless we know your address. And it went round and round, and then a professional had to get involved because there really was no address, according to this woman. And we realized the person we were talking to on the phone was housed in Florida. So the woman was telling her where she lived, thinking she was talking to somebody at least in the state, better yet in the community, the disconnect was enormous. And so surveys say it's transportation problems. In Ohio, all the managed care companies that serve the enrollees, they all have insurance. I mean, they all have benefits that include transportation. And so does, you know, the Women, Infant, Children's Program, and so does your health department, and so does. But the policies in the way those programs get delivered add a layer of nuance to what we understand to be the transportation problem. That if we're going to really affect population health outcomes, all of our insurance companies were looking at us going like, we fund that. It exists. We don't need to create another one of those. It already exists. And so what we worked with the insurance companies to do was to use local drivers. And that's not easy for national insurance companies because they use national vendors for their transportation issues. And so, but it's that kind of really nuanced understanding of what happens when the programs and the policies intersect with the people who have needs, who are trying to take care of their health or the health of their children. That's where the population health outcome work is needed. And I think it's very exciting because honestly, everybody wants the same outcome. And so it's really remarkable that everybody feels like they've opened up their schedule, they have walk-in appointments, we have benefits for that sort of thing, we give people incentives to do this, that, the other thing, and it still doesn't accomplish the goals that are desired. And so that's where this conversation really should start, is what happens when someone tries to use the benefits that are available to them, and why doesn't it work? So the factors are many, and so this conversation gets really big and really complicated really fast. Right, and so you can start with, I just told a 5-minute story on transportation alone. Well, what is it if we talk parks and recs? What is it if we talk, we're in Flint, Michigan, what is it if we talk toxic water supplies? What is it if we talk access? What is it if we talk insurance policies, provider plans? Do we have any mental health providers? And so I think this is the fun of the game because it's so huge that all you need to do is find a set of partners who want to make a difference for an outcome. Go deep, deep, deep into understanding what that outcome is influenced by and make change. And the quality improvement people would say, make record change. You know, do your PDSA cycles and change something and see if it works. Change something for 2 people and see if you get better outcomes. And then you know you got something that you should try to scale. But it's really in the community that work has to happen. Because what trips up one community is not going to be what trips up the next community. And so it's hard work, but it's really doable. And so a new med school that's really articulating an intent to make a difference for a community is just a fabulous thing. Yeah, I just think that's a great idea. So population health then becomes both a means and an end. And so population health if you're public health, or if you've got family or friends who work in public health, I mean, there's this sense that we don't need population health, we got public health. We've been talking about public health for decades. What is this interference being called population health? And population health is the health of the population, but it's also an approach. It's an approach to going from outcome to distribution of outcome to determinants to the policies and programs that are impacting those determinants. And so if I say to you, take a public health approach, most people drop into the public health department. If you say, what's the public health approach to that? What's the public health approach to immunization rates for kids? They offer them. If we say population health approach, people start into a bigger landscape. People step into thinking about the outcome, the distribution of the outcome, the factors, and the policies and programs that hit the factors. And so I think they're different. So population health. My project in Southeast Ohio was a kids project. I'm a pediatric psychologist. And our table was literally, if you touch the lives of kids, you're welcome at the table. We built a nonprofit organization. We built a governance structure for that nonprofit that was constituency-based to prevent ourselves from regressing back to just talking to our friends. It's very easy for psychologists to pull together a group of psychologists to try to fix something. My early work in my community put together physicians and other providers who the pediatricians interacted with regularly. They were referring people from the pediatric office to the speech therapy office, from the pediatric office to the mental health center. And uniformly, people had never met each other. They just send them over there, and you all know this line, anybody who refers to mental health, because it's well documented in the literature, and then you never hear anything back. And mental health stands on its platform of patient confidentiality, and unless Mrs. Smith wants me to tell you about what I did with her child, I'm not going to ask. But even then, the mental health system says we faxed you the results, and the person at the fax machine in the office says, we never got that. Or if we got it, it's not in the chart. Or if it's not in the chart, it didn't get scanned. Or if it didn't get scanned, it's sitting on the physician's desk because they have to initial it and date it before it gets scanned into them. And so just pulling people together who work together was novel in my community. To go across the siloed system and build a table where a conversation could be had. And I don't really know if it would be novel in this community, but probably yes, because people's lives don't allow for that time to intersect. So who gets together to do this work depends on relationships. You start with the people you know, you start with inviting your friends and your family and people who you know care about an issue, but the door should always be open because the potential changes every time you pull in the next system. And so if you're going to do immunization rates, for example, and you get the pediatricians together with the health department because they have the immunization clinic, and then maybe you have a free clinic in your community, well, now you got the side of the medical universe dealing with each other. But what if the schools, what if you could get those kids earliest through the schools? And what if the public health person could be at the school, and places do this already, on kindergarten screening day? And what if, okay, it's not really schools because they can't go to schools until they have their shots, so what if we back it up from there? What if we're at the daycare centers? And so now your doctor's office has a whole nother level of relationship with another part of the system that in their daily life they don't usually interact with. And so all the doors have to be open all the time. Any of you who sit on boards for foundations or school structures or the library structure, there isn't a door that can't contribute to an agenda to improve a health outcome. And so this is the idea that the collective action of a community has to pull together. And what happens in a lot of communities is people do a lot of good programs, but everybody's chasing a different outcome. And so the hospital board takes on helmets on bicycles. The school board takes on maybe early immunizations. Everybody picks the same thing. Well, think about what happens if everybody gets behind the same agenda. That's what you guys, you're at the start of that conversation. That's what you guys can start to make happen in this community. You get your multiple sectors all deciding that the thing that matters most to us is this. And you all tackle it through your door. And so that's collaborative action. There's also a literature on something called collective impact. Those ideas are one and the same. Any thoughts, reactions, the glaring light makes it very difficult to read the audience here. Any opinion on your community? Are you doing this kind of thing yet? Are you trying to? Do you want to? I know a handful of names in the audience. I might start calling on people. Yes, go ahead. Thank you.
So in terms of, sort of teaming together with schools and sort of early childhood development, I'm a primary care physician, telemedicine physician in a rural community, and this was about 2 years ago now. The state of Arkansas instituted that all children, they started requiring them to show and prove that they had their vaccines at a certain age, and actually changed the vaccine schedule to make it align with the American Academy of Pediatrics.
Right.
Which they really hadn't done that well before. And they told the students you have to get vaccines within 2 weeks or you can't come back to school.
So that was jarring for a lot of people.
And so that was their way of getting them to get vaccines. Well, there's not enough healthcare providers
to meet that
to the vaccines,
time.
nor was there a supply, enough supply of vaccines to do that. So as a local pediatrician, I was getting calls from a lot of school boards and everything to try to get these students in. What we realized was that not only were they lacking vaccines, but many of them hadn't
been to the
well child
doctor,
check.
right.
Hadn't had their well child check in about 5 to 10 years, because these were like 11, 12-year-olds. So we sort of had to come up with a system in order to get these kids in sort of a rapid period of time. So we took about 2 to 3 weeks, and we bused 35 students a day to my office to get well child checks and immunizations from a different local area schools. And we had to continually order vaccines and had problems keeping up with vaccine supply just from the state, getting enough from the state. And it was one of those things where I think the state had a really good idea to try to get these implemented, but they didn't really ask anybody of how this was going to take place.
Right. One sector knew what they wanted, and they forgot to talk to the other sector about how it would happen. Right.
It ended up working out, but it took us from October to December, so to get all the students in a good time frame, because I still had to see regular patients too. But it was just an interesting, idea of how, putting in place these policies, you may not, recognize the downstream effects of what it does to that population. And taking the kids out of school for a day or weeks.
Well, and the stress on working parents, like, what do you mean my kid's not going to be able to go to school in 2 weeks if they don't get shots? I called, they're not available, and then somebody thinks the parent's lying. Did you really call? Do you have proof you called? And
Right. They had to have notes saying that they can go back to school, or that they had seen me, but we didn't have any more vaccines, so they were going to come back in 2 weeks to get a vaccine. It was just a disaster.
Yeah, that's an excellent example. Thank you. I appreciate you sharing that. Barbara.
That's the dare to ask.
Yeah.
What's the relationship of population health strategies that you discussed to the reimbursement system or
So I think you're raising the question of how does population...
Who pays? Who pays for this?
And can we pay differently so we can do some different things?
Yeah, well, it might be easier to find a new payment source than to change the way that we're currently paid, but, yeah, who pays?
So,
I'm sorry.
as Shane alluded to in my opening remarks, after we built a regional care coordination effort, we had to get it funded. And things have to be sustainable. And this is preempting a little bit of my second hour of my talk, but if the payer, in my mind, is the resource that's going to benefit. And so if we start talking about, we had these meetings in Ohio, we'd start talking about social service-like interventions to improve health outcomes. And all the plans were present. So Ohio's a 5-plan state. We were dealing with predominantly Medicaid enrollees. And our health insurance partners historically are happy to pay for health care and thrilled if they get improved health outcomes. And our social service systems, which are predominantly, line item budgets in the state budget, are happy to deliver social services and feel like they're doing a pretty good job at that. And so the conversation really becomes one about shared responsibility and shared accountability. And so it's the same siloed argument that your example just raised, is who's responsible? Who's responsible for paying if what improves a health outcome is a social service something or other? Is it really the responsibility of the health insurers to pay for social services? And it becomes, in my mind, a very straight-up math equation. And so my low birth weight baby project was really about keeping babies out of the NICU. It was about keeping babies out of the NICU because that is a very expensive endeavor. And so who pays is the flip of the coin, who saves. And it's where the savings lie, where people, in my experience, were more than happy to think about differentially investing. I mean, people who invest in an intervention to affect an outcome really don't struggle with, that's in my ballpark because I'm going to save. And so the big structures, the accountable care organizations and those kind of ideas start to do the shared savings back to the bodies that come together to say we want to make a difference. The majority of that effort is still within the health delivery system. We still don't have many structures that connect us out of health into education, into social services, into mental health. Depends on the state and how the structures flow funds, but who pays, I think, is the simplest starting point is who saves, because the savings can be so enormous that people might be willing to invest differently. All right, so that wiped out slide 37 through 55. No, it's really the triple aim construct that brings cost into the equation. And so Don Berwick, and this is Institute of Healthcare Improvement, IHI.org. This is a great site for those of you who, if there are people who aren't familiar with it, it's really worth exploring the site. So population health isn't public health because population health is more comprehensive. You go to this construct, and population health is just a smidge of the storyline, right? So population health is one of 3 bullets. So we're going to improve quality, patient experience. We're going to reduce costs. And oh, by the way, we might improve population health along the way. And this agenda is really driven, I would say, by cost containment, but not in the absence of a quality argument. I think it's very important to understand that improving quality is a very engageable agenda. Reducing system profit is much less appealing. And so the economic agenda within the triple aim really broadens the landscape of population health and says, well, you got those outcomes, you saw how they distributed, you got a handful of factors you think contribute, and we could change the policies or the payment formulas or the strategies for how we deliver care and see if we get, this is like the trifecta at the racetrack. I mean, right? It comes in with lower cost, higher quality, and improved population health. You've all got to be in this audience familiar with these slides. And so this is the "we spend a fortune" slide. That's the United States way out there on the right edge. And here's how we benefit from that. And so what this one shows, and it's not great resolution in the back of the room, is that the United States life expectancy really isn't robust given the amount of money we're investing. So this is if we're investing all this money in health, this one, paying a lot of money to deliver health care, we really have very poor life expectancy as a nation. So that's, life expectancy is a outcome. You could do 800 more slides on how life expectancy distributes. How's it look in affluent communities? How's it look in racially diverse communities? How's it look in shortage areas if there's no health, if there's no hospital in the community? And so you can look at this 9,000 different ways, but this investment yields very little benefit is what's behind the triple aim cost inclusion. And so cost factors, and thus I applaud Blue Cross's, Blue Shield's role in this conversation, is really, really relevant. We are going to bankrupt ourselves as a country if we keep spending on health care like we're spending today. The resources are not there. The other place population health bumps into the national rhetoric is in the Affordable Care Act. And I just highlight pieces of that really are semantically, maybe the language is a little bit different, but they are addressing the same issues. And so access was expanded through multiple mandates and methods, but nonetheless, the goal was to get more people health insurance and into the health delivery system. Quality, in particular the CMMI grants, CMS is the major payer, federal government level, and there's a CMMI initiative for those of you who are thinking where's the money to really try to start to do these things. CMI grants are usually very large projects within states that look for innovation. They're specifically funding innovation that manipulates cost dynamics and delivers services differently. In Ohio, our big CMMI grant currently is bundled episodes. And so bundled, I'm old enough to remember bundled payments on the inpatient side. Well, bundled episodes start outside the hospital, come into the hospital care, and then go back out into the community. And how do we distribute payment that comes in as a bundled episode payment when it involves people before the hospital system and on the other side of the hospital system? And then how do we distribute payment when those systems are not just physician-owned practices at the hospitals? How do we get the money back to the community so the investment can sustain the interventions that we found benefit the people that we're serving? Preventative care, there's something, I'm sorry, go ahead.
No, I was just going to say, it's just interesting, we started the conversation about southeastern Ohio, very poor and underserved area, and you look at all of the things on this slide, right, and these initiatives are being implemented and best taken advantage of in the largest of cities and the biggest of health systems, right? So where we really need the help and support, the economies of scale are tiered towards the urban population, right? And so,
as are all the policies. I mean, in my state, I constantly ran around and saying policies for the 3 C's, Cleveland, Columbus, and Cincinnati, do not translate. We had one policy, we do a little advocacy work at the state level, that was going to be about chopping preschool funding if you didn't have 20 kids in a class. Well, welcome to Southeast Ohio. We would not have any preschools if we sat around looking, or kids would have to get on buses and, an hour and a half later end up at their 20-kid classroom and stay there for 3 hours and ride the bus back for another hour and a half.
So there's just no trickle-down effect.
Yeah, there is some attention. So I've over the years, I've been pretty active with the Office of Rural Health Policy and the National Rural Health Association, and at the government level, both Mary Wakefield and Marcia Brand were huge rural advocates, and they've currently, Marcia's retired now, but been situated pretty solidly in the HRSA administration. And so you start to see language in some of these funding opportunities that are particularly attentive to rural. So at the bottom, there's something called Community Transformation Grants. The Community Transformation Grant guidance had language very specific to funds. I think it was 20% of the funds had to get to rural communities. And that is nice to see. But again, it's the same conversation. If the tertiary care children's hospital, I'm now at one of these again. I was early, I left, I went back. Doesn't have the relationships with the rural communities, you can write it and it's going to be exactly your experience. Somebody in some urban research, academic, medical school wrote for you, good intentions, but oops, forgot to talk to you about it, what they're going to do with their rural dollars when they get them. And they're just oblivious to the translation factors when the money comes in. And so the Office of Rural Health Policy, I think, is a fabulous office for rural communities because it's money dedicated to rural, and people have worked very hard over the years to keep that money protected. But as rural advocates have really advanced in the leadership of the government, you're seeing more attention paid to recognizing that it's an uneven, even the grant application competitive field is uneven. The big systems pull down the big bulk of those dollars. And smaller community hospitals, it's not that they wouldn't use the money if they could get it, but they don't have the machinery of the big systems to pull in the grant funding.
Same with CMMI.
Yes,
That's where the money
CMMI,
went
yeah,
to.
there was a great, I don't know if it's on this slide. Yeah, so the third bullet there at the bottom, CMMI just competed something called the accountable communities, and I thought, oh, that's like my twin. That's exactly what I'm about. And the accountable communities grant, you needed to be able to touch 75,000 lives each year. And I've got a pretty good network structure in Ohio, so I could make a lot of phone calls, and getting to 75,000 was tricky for smaller places. But this Accountable Communities grant really encouraged people. There were 3 tiers to this funding stream. The first called for screening. And so people go, screening, like, oh my God, this is like a 2016 initiative from the federal government. We need screening because we need screening. And if you go into a practice environment and say, why aren't you screening? Again, I'm peds, so we like to screen for maternal depression, and we like to screen for, we do the ages and stages, we do the peds, the AAP schedule for ages and stages, and then you got to worry about substance abuse, and then you got to worry about teen depression, and doctors' offices they just start crumpling. They just start going, it's not that we don't care. But there's some nice telehealth. There's some nice evidence that people report things in waiting room screens that they're not going to bother the doctor with when the doctor says, so is there anything else we need to talk about today? And so screenings really work, and they're very hard to get adopted because we don't pay for it. The policies don't give you there's a little bit of shift to that, so there's some hope there. But even when they do them, then what do you do with all the information? So like if you did 5 screens, like we're going to screen for autism, and then we're going to screen for ages and stages development, and then we're going to screen for substance abuse, and I got my 10 minutes. What if all that stuff comes up with red flags that we need to do something about? And then where do you send them to get it done? So the very basic CMMI accountable communities level was screen. Then the next one was refer, but make sure they get there. I mean, you know, this is the national rhetoric. Like, how do you do that at physician education level? Like, when you make a referral, you ought to know that most people, you know, we say it about the antibiotics, you know, when you fill the script, a lot of people don't finish it. But when you make the referral, people don't get there. Or people who are fragile don't get there. Or people who need more supports than, I want you to make an appointment with so-and-so, go make it, don't get there. And then the last level of the CMMI Accountable Community Grant, which was the one most interesting to me, really started to hint at aligning the sectors. Because that's where I think the rubber hits the road. If we screen, and then we make referrals, but nobody makes sure people get to referrals. And then when they get there, nobody talks to each other after the information comes in. You've got a system that is just spinning in inefficiencies. And population health outcomes don't change. So I think what this conversation is really about is, and this is a PCORI grant line. I mean, PCORI is the Patient-Centered Outcomes Research Institute. And it sits beyond the federal government. It was established to be an entity that sits outside of, it's not a .gov on a URL, is that you really got to be talking to the people you're serving. And patients need to be much, much, much differently in conversations. And how do you do that? How do you do that as, you know, how do you get patients to start talking to you about what your curriculum really needs to include? How do you get, you know, a lot of hospital systems have patient advisory groups or components of diseases do. So if you're a transplant center or you're a big center, those places often have a mechanism to get the voice of a consumer into the conversation. But for those of you who have been close to those conversations, you get very professionalized consumers. When you have one of anything at a table, it's very hard for the one to dent the policies and patterns of care of the table. So we sit, IPAC's guilty of this, my nonprofit, we have parent representation on the board. And we've debated for years whether we need a parent board with professional representation. And how much different do the ideas look if it's the patients coming up with the intervention ideas and the policy suggestions than the system? And that's just an interesting conversation. What is going to work for whom in what context? And it's difficult work because it's granular, it's down in the weeds. But that's how population health is going to shift. So when you're preparing slides for a talk, of course, you're very attentive to what's going on in the conversation at the national level. In this first report here, there's an IOM, Institute of Medicine Roundtable on Population Health, that's a good source of conversation. But this report in particular is just published this week. Is really about metrics and about the dizzying level of data and what happens when we try to use that data to translate it into action. This is a workshop summary report, and for those of you who aren't familiar with that language, what that means is they got a bunch of experts together, they sat around and talked all day, they did a couple of little exercises, somebody took notes and they published it. So it's a very honest exchange of ideas between people who are deepest into this conversation at the national level. 75 pages, sounds long, but it's really a pretty efficient read. I recommend that to everybody. The other thing that happened, I think we're still within the week, is Don Berwick, father of IAHI, Triple AIM, came out with a viewpoint paper in JAMA saying the accountability reporting is killing us. People's morale is in the bucket. And where's the civility in the conversation, and how do we make a difference? How do we get beyond greed and profit? And he really calls for people to refocus on quality. That one's 2 pages. That's an easy find, and thought-provoking. So both of those. So population health is not only important, but it's also very, very, very current. There's a lot going on in this conversation nationally. All right, so you can easily get lost in the data, and so I decided, since I was coming to Jonesboro, Arkansas, I needed to learn a little bit about Jonesboro, Arkansas. And so I chose the Wisconsin County Health Rankings metrics, and I picked them in particular. There's a lot of choices, because the intention of this measurement system is for communities to have conversation and try to make changes. That's why the thing exists. So the first year they published, they immediately came up with a roadmap to population change right after it, and another website, Wisconsin County Health Rankings, that has fabulous resources if you're going to try to go from an outcome data point into a policy or an actionable intervention to make a difference. And so for those, I assume this probably speaking to the choir on this topic, but County Health Rankings looks at both health factors and health outcomes. And so these are how they divvy up factors. And so you got 4 broad categories, and those are illustrations of the types of variables that fall under the categories. Each one of those variables is tied to a national data point in some sort of national data generating structure. And so it's aggregated, and you can look at trend data on their website. And so, again, this one doesn't project very well to the back of the room, but this is the preventable hospital stays in Craighead County. And so, if you go back here, we're looking at a clinical care measure, and there's your graph. Blue is you, gray is your state, and orange is the US trend. And so, blue is you, Craighead County, your preventable hospital stays are coming in between. Your state averages are higher and the national averages are lower. We look at another trend, here's adult obesity. And again, blue is you, gray is your state, and orange is the US numbers, and you see a different position. And so there's trend line data on all of these data points in the Wisconsin County Health Ranking data set for all the health factors as well as health outcomes. And so on the health outcome, the big variables they pick is length of life and poor quality of life. And so if we take your county as a whole, I now know there's 75 counties, I think, in your state. Health outcomes-wise, Craighead County comes in 10. Yay, team. Congratulations. That's a fabulous number. And then your health factors, you're doing even better than that. You're doing even better than that. And so those are very interesting numbers. And there's a few quizzical eyes out there for people who probably are in the health delivery world and go, oh, I don't know if I agree with that. Here's your state. Again, every state, every county, all this is off of the website. Craighead is lightly shaded because Craighead's 10. Look at your surrounding counties. You go north to green, you're okay. You go east, we have a very, very different picture. You go south, and you go deeper south, and deeper south, and deeper. It's sort of like the podium you're standing on top of is really challenged. Yes, go ahead.
Which, of course, and for those in the room know this is based on resources. We know Craighead County in northeast Arkansas is the pinnacle of healthcare in this region. You've got the 2 largest hospitals, the largest per capita number of physicians, specialties. Some of that extends up into Greene County. So it's easy for even someone not from Arkansas to see where the resources are.
Yes, it was easy for me, yes. Yeah. And then I think the other ones were your triple C, right? You know, the lighter shaded areas in the biggest cities with the biggest systems in them. But if this region is going to take on population health, you can stop today if you're talking about Craighead County. If you're talking about the health of a broader population in a broader area, there's a laundry list of things we could probably do. So then I took the 4 counties that immediately surround you, and on some level, there's probably a little bit of like, oh, we probably should be doing more for our neighbors. And how do we get what's working decently in our county, working decently for the other counties? And you're all out there going to access and transportation. And I'm here to nag you that if you're going to say it's access and transportation, try to understand really what access and transportation means for those communities. Because honestly, if you could prevent a diabetic by buying a family a car, somewhere there's a return on investment there. But we all know it's absurd. Buying a car is not going to prevent a single incident of diabetes and its associated morbidities. So you've really got to dig if you want to do this. So the national data is helpful. It tells you where, it's a compass, it points in a right direction. But the work is in the community. The work is really between you and your neighbors, outside of the health delivery system, talking to people you might not already be talking to. Even in Craighead County, you got disparities. You got outcomes, and this look is, the federal government tracks something called medically underserved areas, MUAs, and the federal government also tracks HPSAs, which are health professional shortage areas, and HPSAs are measured for primary care docs, HPSAs are measured for mental health professionals, and HPSAs are measured for dental. And HPSA MUA, it's just a Google HPSA MUA, you'll get the portal, you type in your zip code, and it will show you what communities in your county have real shortage areas. And I know nothing about these, but I'm sure everybody in this room knows this list deep. And we probably even have been caught in a conversation or two when we have somebody no-show for an appointment, and we go, well, yeah, they're from. Because we know the behavior in these neighborhoods at these zip codes is different than the behavior in other neighborhoods and if we're going to fix population health, we don't just say, well, there's really not much interference, we're 10 overall. We care to get into those communities and really understand why we're not one. So, Barbara, this is where you preempted me a little bit ago, but sharing the responsibility and sharing the county, the accountability across sectors, I think, is really the important piece. And so, you got to decide to do something. And it's possible to get overwhelmed, because as you try to drill down behind an outcome and its distribution, you think it's transportation, and then you tackle transportation, and then you get, well, I'm not so sure they just even really value health. Or in Appalachia, there's a lot of fatalism. You can die of something. Everybody in my family died of that, so, that's just a given. That's it. I'm not going to spend my time not smoking and not eating this, that, and the other thing. What are we going to do about health behaviors of populations? So I think that's the richness that bringing together the systems can get you to. This slide echoes earlier remarks I already made about how if you're going to do something, do it together, do it collectively, and agree on how you're going to measure it. This slide gets to the issue of governance. And at dinner last night, we had a little bit of conversation about this, because it's in the literature. The IHI folks talk about it as an integrator, and the collective action folks talk about it as a backbone organization. But there's enough suggestion that it's very difficult for systems to come together and not come to the table with their siloed interests in mind. And it takes some pretty sophisticated leadership to start seeing where the win-wins are without asking people to change their missions. And so really understanding in your community, as you pull together disparate organizations, who has those skills is valuable to think about. Because it's going to be a long time before an insurance company comes to the table and says, I'm worried about third grade reading levels. And the third grade reading teacher is not coming to the table and saying, well, the profit margin's down at Blue Cross Blue Shield. And so you have got to figure out how to take the mission and interests of the siloed partners and find, it's cliche, but they're win-wins. And they exist. The win-wins are really about translating one person's idea into the other person's interests. And so I encourage folks who are thinking about going into this work to think about what level of connectivity they build for projects. And governance might be a little strong in some arenas, but governance isn't a bad way to think about it. What's going to keep the conversation transparent? How are we going to get the partners to trust one another, to really understand what they're doing together? And so I just think it's important to bring that to folks' attention. And of course, it's your afternoon workshop, but once you start doing this work and the knowledge and data starts coming back, what do you do about it? And how do you apply what you're learning about the efforts you're doing? All right. This is where I put our break. This is also where I put a awesome, awe-inspiring video that some of you may have seen. But before I play the video, Midpoint remarks, thoughts, comments? That was what I thought population health was. That's really different than anybody? All right. So I'm going to play a video. You can watch it if you want. It's a good video, but you might not want to watch it. And then we'll reconvene. All right, now, I had training on this morning, and it's not looking like it's going to work. Here comes my training team. All right, I'm pretty sure I just hit the link. The link should work. We pulled it off, but. Yeah, thanks. So if you've seen this, I apologize, but I love this video because I'm a kids person. But this is now that you know you got something to go do it. So here we go. Take a break and we'll see you in 10.
Yeah.
All that work to get it to play right.
I appreciate it. Oh, yeah, absolutely. So she's in, they give us a list of they give us a list of areas that are underserved, areas that she's in, not she's already on the list. And so whenever
The results are
we get one of the but yes, she lives certainly
and they call her right to Florida.
yeah, I'll have to say yes.
Okay, so as we're getting close to 10:45. Okay, let's go from your point of view.
still do that. They're in the,
This is going to take long. So trying to take over the question in terms of there's actually quite a bit but after that,
That's right, but you know, that's the basis of the
We got a desk, we got a phone.
there's no incentive. Most no incentive to manage a population. John Campbell was he's a pro. He's a smart, dirty guy. I think he helps like this. He said he's got birth control impacts like that. I think it's sociology. CASTERLIM. So here's my definition of population health. Maybe we can get to the next slide. It's if I'm a doc and I have 2,000 charts on the wall, I see 30 pages that week. My definition of population health is, okay, what am I going to do for the ones that didn't come in? What are my responsibilities for work like that? Now this time I have 5 docs, we check the patients, that's 10,000 people. We see a total of 100 that week. What are our responsibilities? What are we going to do about the 500 that didn't come in this week? And that seems to me like that's what we're in terms of practice and being a practitioners. We just get, I mean, that's the biggest question in dealing with practices is, I know you can do a good job, but once you came in the door, what are you going to do about the ones you haven't seen for 2 years?
And is it really, is it the doc? Is it the right person on the team?
No, it's the practice. I say practice. It's the practice. Once there's public practice towards those.
Not yet.
Yeah, and should it be? Yeah, I think that's, because when you sit down and talk about things, so I'm almost on these practices, to me that's the biggest attitude switch. I do a great job with these. Pick up the vaccinations. Okay, that time I'm doing a great job with that's the biggest, that plus the cultural change of worry about how things go. I think we're getting good in these bubbles here.
In the bubbles. There you go.
Well, thank you for being here.
Well, thank you for convening the discussion.
Yeah, good.
Should ask you what quote about it. That's really an interesting way of looking at it. I think that's a way to talk to practicing clinicians. That it really, it's like a script way to flow on the policies, and that really gets out. And so, from his perspective, it's like he's trying to get people's awareness that just because, like the pediatrician said, these kids haven't been to a doctor for 5 years. And I think that's sort of a long position. They have to get the first time in 5 years and get a lot. So. I think it's.
Yeah, Scott, what's your thoughts? I appreciate it. Duly noted. Roll back in here. As long as we've had lunch now.
I'm just going to use it and mark stuff out.
Yeah, so it's in here. This is maybe on the original.
Of course, Steve,
Hey Josh, we want to check and see if this gentleman's presentation is on here, ready to go.
What do you got?
that's
Since it's password, can you open it? I can change it. No, I it's good to
Yes, absolutely. Election.
Hello, test. Is it not on? I don't know. No, it's not. Hello? There we go. Okay. We'll go ahead and continue with our agenda. But before we get started, I want to make sure that everyone knows we have the availability for the presenters to be able to get the slides to you. The only way we can do that, though, is to make sure your email address is updated. So when you registered this morning or when you checked in there at the front table, if you'll make sure we have your correct email address, we'd be glad to send you the slides from our presenters, because I know there's some really good information specifically on that first presentation, the first presenter we had, and I know there will be more to come, especially tomorrow as well. So we'll be glad to send you these slides if you'll just make sure that we have your correct email address.
Okay, thanks.
I think we're going over that. Do I need to swap this out for you in a minute? Or?
I'll swap it out.
Okay.
Fine. Hi, folks. My name is Sebastian. I want to thank you for having Jane and I come speak to you today. And I just want to take a few minutes to go over the results of the survey. So my background is I deal a lot with data, and one of the principles I like to apply is that we need to use data. And so I just want to go over the results with you and show how they're germane here. While I enjoy doing very complicated stuff with data, I also like simplicity. So this little bubble chart here shows, with respective size of the bubbles, who was represented among the 32 respondents of the survey. So thank you for completing the survey, and I'll go over the results here. But as you can see, the big purple group up there in the upper right-hand corner are some of you identified on the survey as healthcare administrators. There were non-physician faculty members, physicians in clinical practice, physicians in faculty role, physicians in administrative role, and insurance company personnel. So let's look at the actual results here. So let me explain how I set this up. Here at the bottom is 1, 2, 3, 4, 5, and it's hard to see because the screen is cut off a little, but that's okay. 1 is strongly disagree, 2 is disagree, 3 is neutral, 4 is agree, and 5 is strongly agree. And what I did is I put a nice red line so that visually you can see where the centrality of it is, and I put this yellow band here to show that if you've got a mean in that range, it shows that overall people's responses are neutral, which is sometimes as telling as when they're on either side. So let's go through the actual items very quickly. The first item read, collaboration is simply too vague a construct for me to worry about in my professional relationships. The point we're trying to make there, folks, is that population health involves collaboration. It's just a requirement of it, and so it's nice to see that on average you were about mostly in disagreement with that. The second question read, population health does not impact payment mechanisms for health services delivery. Again, we had a good outcome. We're good, folks, 2 for 2. It's good that y'all tended to disagree with that because population health is directly related to impacting payment mechanisms. The third one was we asked all health providers, including physicians and non-physicians, need to work more closely with one another. Now you're over on this side of the realm, which means you're in the agreement side. That's also a good result. So 3 for 3, Barbara. You can count here. This is good stuff. And then the fourth one, we asked about dealing with issues like poverty and low literacy is clearly outside the scope of responsibility for physicians. It's very favorable to see that in general y'all disagree with that statement. So we're getting a lot of favorable responses here. Health providers, including physicians, have responsibility to integrate social services. Again, a favorable response. Healthcare has no business taking part in providing financial incentives to consumers. This response here really surprises me. I would have really thought that there would have been more disagreement with that. And so it's a favorable response, but I thought it would have been different. So anyway, what we did here with this survey is that, we went through those 15 items, and I'll cut it off here and you can look at the rest of them as I just talk for a minute, is we looked at those items to see where there might be problem areas in terms of moving forward in terms of the collective beliefs. Let's look at this one down here. The phrase population health refers simply to taking a health service normally used for an individual patient and then, I guess that was cut off because of line. And then basically efficiently administering it, efficiently and effectively administering it. The reason why that is in the neutral zone is that y'all probably tended to not really know whether that was about population health or what have you. The point we're trying to make here is that when you use data collection systems, that you first of all come back and first of all know who's sitting at the table, and that's important. So, you want to see, you want to see who's sitting at the table in the first place. And then, when you come over here, you can begin to compare the perspectives. And while I was there, and I'm not going to go into it now, but I did start looking at what were the different perspectives. So here are, the averages for physicians in clinical practice. We can look at instead at just physicians who have primarily a faculty role. We can look at healthcare administrators, and we see that the bars change a little. It's important that when you're looking at data, that you compare and contrast these perspectives because, in essence, population health is bringing a diverse group of stakeholders to the table to try to affect change. Okay? So I wanted to give you that, and I guess the results of the survey, if I can keep it simple, is I don't know if it's social desirability or if it's just the way it is, but the good thing is that the diverse stakeholder groups in here, defined by those roles that we asked you on the first survey question, you all tend to have pretty consistent beliefs and attitudes regarding this stuff. And so I think that's a good place to work to start from. I think that's a good starting point. And I would encourage you to move forward with that. That being said, I'm gonna shift it back over to Jane in a second, but I just wanted to give you an outsider's perspective. So I know diddly squat about provision of healthcare. My background is as a statistician, and so I enjoy coming in as an outsider because, as someone ignorant of the topic, I think I sometimes ask what are good questions. Just based on my ignorance, I ask things that other people are maybe too scared to ask. So when I first met Jane this past fall, and she started talking about IPAC. Which first of all is an acronym, so it's like, oh, here's another acronym, to the 2,000 I already know, which stands for Integrating Professionals for Appalachian Children. It really was like a word to me, and I just want to say that I've really encouraged her to share this notion of IPAC and the structure because it really works. And some of the stories about some of the downright funky ways that they brought together community stakeholders to address the health needs of children and help ensure better population health has really been extremely effective. And so let me switch computers here, and Jane, why don't you come up and talk about IPAC.
But thank you for participating in the survey. And if you want, I will write up a little summary about it without revealing anybody's identity, and share that as well so that you can have that with the PowerPoint slides. Okay?
So as Sebastian's like getting me technologically connected again. Thank you for those comments on IPAC. IPAC, somebody that I was talking to this morning said, oh, the telehealth guy is going, oh, I love my telehealth project. I love my IPAC project, because you get very connected to things you invest a lot of energy in. And so it's nice to hear folks come along and say, well, that looks like it's really doing something different. And given our time, and I have a timekeeper now in row 3, and I'll share all the slides, but I'm gonna truncate kind of how many slides I can get through here to not leave you all dizzy and nauseous speeding through slides. Date modified. Just sort by date modified.
They're all 3.9.
Yeah, they all have timestamps.
Okay. And they're all within a 6-minute window.
Oh, I'm the population. Well, I don't know which one I am. And so I think the best place to drop us in my IPAC story is probably into our effort to use pay-for-performance contracting to improve health outcomes. And I put us there because incentive-based payments work a couple of different ways. This is the wrong presentation. I love technology. Incentive-based payments work a couple of different ways. So, given who we know is in the audience, folks are very familiar with HEDIS measures and how HEDIS measures are being used as aggregate points of data for populations of enrollees in an effort to try to improve performance. Thank you. In a different spin, pay for health outcomes is also an opportunity to strictly tie payment to a desired outcome. So, all right, I'm going to speed through slides here to catch us back up. Can I get the slides so they're visible on the screen? Thank you. And so what this project was about was, so the landscape here is a 4-county region, 8-county region of Southeast Ohio. And there's quite a bit of conversation in the national rhetoric about the importance of care coordination. And care coordination is really getting bantered about as the solution to all the social determinants that interfere with outcomes. And it's an expectation that the systems will employ care coordinators, because the systems will have payment that is incentivized by improving the outcomes, and that the personnel that should deliver those improvements is not the doc getting in their car and driving somebody to their appointment, but other resources in hospital systems. Well, in rural communities, the ability of small practices and even hospital practices to employ care coordination starts bumping up against margins, and it starts challenging our ability to do what we do well. So what we did in rural Southeast Ohio was we built a distributed workforce, and we tapped into what I would call slack or capacity within the social service system to train care coordinators who were accessible by the rest of the delivery system. And so that workforce was then tasked with trying to improve health outcomes. Thank you. And so that's all, that's 6 slides, so that's a really condensed version here. But what this is a use of a workforce that sits outside of the provider's practice, be it a hospital, be it an OB/GYN office, be it a PEDS office. And you can make referrals through our integrator hub organization in order to get to that workforce. And we took on the risk by entering pay-for-performance contracts with our plans to try to dent the outcomes. This one I think I can solve. Do it from the current slide. We should be... I apologize for this.
Which slide was it?
I'm set to go. Yeah, why don't we take 5 minutes and see if we can get the technology. I apologize.
It's the one that starts in B.
We apologize for some technical difficulties. Obviously, those can't always be. I'm sorry. Yeah, so speaking of technical difficulties, if I could work the microphone, that'd be one. We apologize for our technical difficulties, but actually we are on schedule right now. I think we'll pick up a few of the topics that were going to be mentioned just a second ago in this discussion as well as in our panel discussion. So right now we'll actually move forward hearing from Mr. Carl Kellogg and Mr. Steve Spalding. I'll give you a little bit of background about each of those individuals as they start to come to the podium. Carl Kellogg is the Executive Vice President of External Operations and Chief Strategy Officer, whose responsibilities include oversight of the strategic and annual planning process, diversified activities, sales and marketing, provider networks, and medical management. Kellogg joined Arkansas Blue Cross Blue Shield in 1995 as the Director of Plan Development and Integration. He was promoted to Vice President of Enterprise Development Services in 1997, and in 2009 was named the Senior Vice President of Strategy Development and Chief Strategy Officer. Prior to joining Blue Cross Blue Shield, he served in various administrative and teaching roles at Arkansas Tech University, Illinois State University, the University of Mississippi, and the University of Arkansas at Little Rock. He received his bachelor's and master's degrees and Doctor of Philosophy in Business Administration from the University of Arkansas at Fayetteville. He has received professional status in the Association of Healthcare Management. He's the former chairman of the board for the Governor's Quality Award and is a member of the University of Arkansas at Little Rock's Executive Forum Advisory Council. He serves on the Association of Health Insurance Plans Executive Education Advisory Board. He also currently serves on the Arkansas Health Data Transparency Board. Mr. Steve Spalding joined Arkansas Blue Cross Blue Shield in 1983 as the marketing representative in the Hot Springs region and was named an account executive in 1991 for U.S. Able Administrators. He was named regional marketing manager for Eastern Arkansas in 1993. He serves as the regional executive for South Central Region headquartered in Hot Springs from 1994 to 2002 when he was promoted to the Vice President of Internal Operations. In 2008, he was promoted to Vice President of Enterprise Networks. A native of Breckenridge, Michigan, Spalding received his bachelor's degree from Alma College in Michigan. He is a chartered life underwriter and a certified health consultant. He received professional status in the Association of Healthcare Management in 2005 and completed the Ross School of Business Executive Education Program at the University of Michigan in Ann Arbor in 2012. He has executive responsibility for payment reform initiatives for Blue Cross Blue Shield and its family of companies. These include establishment of collaborative health ventures and clinically integrated networks. Also includes oversight of implementation and support of the patient-centered medical homes, provider network contracting, enterprise business intelligence, hospital reimbursement, and commercial pharmacy programs, which means that he is never home. So it is with great delight that I invite these two individuals to the podium to give us an update on Arkansas Healthcare Payment Improvement Initiative. Thank you, sir.
Thank you very much. Well, I'll start off the presentation, and I'm having a flashback being a recovering academic. I'm back in a classroom, and I notice everybody's at the back of the room, which is normal. I hope you caught from the introduction that prior to coming to Blue Cross, I couldn't hold down a job. But once I got there, I've been there 20 years, and Steve's been there his whole career. So I guess the key takeaway is once you go to work for Blue Cross, you never leave. So I'm not sure what that means for all of us, but what I'm going to do is just kind of very quickly talk a little bit about the Arkansas Medicaid expansion and the impact that has had on the state and where we may be going with that, because I think that also ties into the whole discussion around population health management, because several different things happened. The approach that Arkansas used to expand Medicaid really helped the commercial payers start to align with some of the activities in Medicaid and start really looking at some things. Now, being an academic, I have to go back and do a little bit of history and talk a little bit about the two critical components that were really created by the ACA that allowed for Medicaid expansion to occur the way it did in the state of Arkansas. The two major components there, first off, is that Initially, you'll remember in the ACA, it required Medicaid expansion based on strictly on the federal poverty level guidelines. No other set of criteria there. So it was mandated that a state had to expand based on up to 138% of the FPL if it didn't already exist. Now in Arkansas, it was 17% of the FPL with the exception of some specialized groups. So that was a significant expansion. Second major component was the idea that there would be subsidized coverage via the exchanges on the based on FPL from 100, and that should be from 100 to 400%. And there was actually an overlap there between the 100% and the 138 because Medicaid went up to 138, ACA went from 100 to 400%. Now remember, there was the challenge, one of the several challenges to the ACA that have gone along, but the first challenge was the constitutionality of the ACA, and the Supreme Court ruled that the ACA was constitutional, even though it wasn't called a tax. It really was a tax, and because the government had taxing power, they could do that. But the part of the ACA that was ruled unconstitutional was the fact that the Medicaid expansion was coercive, and it required states to expand. So that's when it opened up the door for states to decide whether or not they would expand. So Arkansas, as the other states around the country, were all faced with the choice about whether or not to expand. Now, Arkansas took a very novel approach. And there were several policy issues or key factors that kind of drove that approach. The first thing was the existing Medicaid program was very limited with the exception of coverage for pregnant low-income females in the RKids A and B program. So basically, if you were a younger, healthier male, low income, above 17%, below 138% of the federal poverty level, you really didn't have much of an option for being covered under Medicaid. You had to be a special, in one of the special segments of the population. It was a very limited Medicaid program from that perspective. There was a significant opportunity to provide coverage for a large number of low-income Arkansans. We're now at about 260,000 newly insured people under the Medicaid program as we've expanded it here in Arkansas. Consequently, Arkansas is only behind Kentucky in terms of the decrease in the uninsured. So now what's happened is we've got so many more people in the insurance pool, it really drives the need for looking at population health management and payment reform that supports population health management. The other thing that was a key factor in the state to look at was the match reduces to, it starts out at 100% federal match. For the first several years of the program, the federal government pays for the full expansion. Even in the worst case scenario, in out years, in 2020, it drops to a 90% match. That's still better than the 70% match that you have on the traditional Medicaid program. And then the rules for the ACA qualified health plans and how they were structured in the essential health benefits, we saw an opportunity to align the alternative health benefit plans allowed under the Medicaid program with the EHBs, the essential health benefits, and you could literally have what looked like a commercial product at commercial reimbursement rates that served the Medicaid population. And that was a very unique approach that was being used, and it had a lot of positive uptake because of that basis. And so that came into play. And then everybody realized that there was going to be the potential significant amount of churning between the Medicaid and the exchange products, and you would have gaps in care and you would have issues with different provider networks and so forth. And by doing it this way, we've basically eliminated the opportunities that you have for the gaps in care and the differences in provider networks and so forth, because basically it's a commercial product. And dealt with in the same form and fashion as a commercial product. In their particular network, individuals and groups that really, that's an important issue. So what Arkansas did was they passed the Arkansas Health Independence Program, also known as the private option. That's what everyone talks about. Section 1115 waiver. And basically what the state did was the state used federal dollars, that 100% match for the Medicaid dollars, to purchase a silver qualified health benefit plan on the exchange for the newly eligible Medicaid. Now, in order to meet the Medicaid requirements, they had to take the silver option plan that was at 94% actuarial value and enhance the benefits and bring those benefits up, and they had to do wraparound and so forth structure. But those were some of the things that the insurance companies worked with the state to develop a methodology for doing this. The important thing is the state's not on the risk for this. The insurance companies are on the risk for this. And so we're acutely interested in managing the population, this newly eligible population, and working with the costs, because now it's part of the insurance pool. And it affects the pricing, it affects the products and so forth that are offered in the commercial markets. And so it's all one and the same now. And so we take the approach that whether it's Medicaid private option or Arkansas Works as it's morphing into, or the commercial market, it's one and the same. There's no difference. And so from a provider perspective, you're not looking at treating patients or anything in any different methodology, because it's all the same, one product. Or at least that's our philosophy. Now, the initial results, the figures are about 267,000 people that are being covered now, and those are primarily 18 to 65-year-olds between 17% and 138% of the federal poverty level. There has been a significant decrease in uncompensated care in the state of Arkansas. There's been nearly $1 billion of federal dollars that have come into the medical community because of the private option and the federal dollars being sent in. It's improved continuity of care for some groups originally covered by Medicaid, particularly pregnant females. One of the things, for example, that we've discovered is the Arkansas program, if you were low income, when you became pregnant, you went on to the Medicaid program if you met the threshold in terms of the income level. Once you delivered the child in a certain number of days after that, you went off of the Medicaid program, and there may be a gap in coverage. What's happened is the pregnant females have the opportunity to choose to go on to the private option. They choose to go on to the private option, and so they stay covered. They're covered to begin with, they stay covered, and so when the pregnancy ends, they continue on with their health coverage and so forth, so you don't have the gaps in care that you've had for that particular population. And the one last thing that's important to the state is the latest report in terms of the consultants and looking at the fiscal impact on the state is that if Arkansas decided to end the private option or end the Arkansas Works program, the net result would be about $757 million additional costs for the state over 5 years because of how they would have to deal with things. Where we stand today, this is going to be a continuing hot potato in terms of discussion, but the private option does end in 2016. Our governor has proposed a new Section 1115 waiver with some modifications and it's titled Arkansas Works, but basically it preserves the overall structure of the program. It does put in some work requirements. It does put in some premium cost sharing for people at the 100 to 138% level, a minimal cost premium share there. The task force that he appointed to study this and Medicaid expansion voted 10-2 to support the plan. So that will be taken up in the upcoming special session and also the fiscal session, and it will require passage, and then we'll have to go through the Section 1115 approval process. So bottom line is this program may or may not be around for another year, but if it is around in the future, it creates a wonderful opportunity to keep the state aligned in terms of what we're doing in the commercial market and in the Medicaid market. The thing about it that's really intriguing is that in Arkansas, because this is the state expending money, it has to go through the fiscal session. And in Arkansas, you have to have both 75% majority in the Senate and 75% majority in the House supporting that fiscal bill. And so that means 10 no votes in the Senate or 26 no votes in the House could derail the Arkansas Works program, but it would have significant impact on the state. What we hope happens is that Arkansas Works is approved and doesn't become a year-to-year political topic. We hope that keeping alignment between Medicaid and commercial markets reduces complexity, variation, and care gaps for folks. And we believe that having major funders, carriers, Medicaid, and Medicare aligned and focused on improving care for all of Arkansans will have a much higher chance to make meaningful improvements. And that's really where I'm going to hand this off to Steve and let him talk about payment improvement initiatives, because that's where we're starting to see the moon and the stars and the sun begin to align with all of the major payers kind of getting on the same page. So I'll turn it over to Steve.
Thanks, Cal. Kind of timely, this discussion today. I came back yesterday from a meeting in Washington with the America's Health Insurance Plans. I was on a national discussion panel about alternative payments. Secretary Burwell was at that meeting and spoke very intently about the need and the desire and the intent of CMS to lead the country through public programs to value-based payment. Dr. Patrick Conway, who is the Chief Medical Officer of CMS, also spoke yesterday. And it's very interesting to hear Dr. Conway talk, because every time he talks, he mentions the state of Arkansas and what is happening in the state of Arkansas, because a lot of places are beginning to understand that payment transformation is about to happen, and they're starting from a place that we started in 2012, and that's where I'm going to pick up this conversation today. In 2012, Blue Cross had a conversation with the governor's office about the fact that the budget office was looking at some pretty significant deficits in the Medicaid program in the not too distant future, and they wondered if the largest commercial payer had enough in common with the state's Medicaid program to work together to try to figure out how to pay for medical services better. And we had some conversations, decided that we probably had more in common than we thought. So we sat down, we hired a project manager, and we got about the business of what ended up being the Arkansas Healthcare Payment Improvement Initiative. That really is an infrastructure that the federal policymakers are looking at very closely to try to create templates to at least offer up and suggest might work in other rural states around the country. There are probably 30 states in the country that have a makeup similar to Arkansas. There are some states that have more of an urban population that probably won't work as well. But it's very, it's a very nice thing to be able to sit in national meetings where people point to Arkansas as potentially a blueprint for some things that could work nationally. So where we started in 2012 is where my part of the deck starts off. We began to discuss Arkansas. It's a poor state, at or near the bottom on national health indicators such as heart disease and diabetes. The health system is hard for patients to navigate. There's not a lot of integration, especially back in 2012, there wasn't a lot of operational or financial integration in the delivery system, pretty much a cottage industry. And at that time, healthcare was growing unsustainably, and the Medicaid program was, basically doubling in the last 10 years. And as I said, there were large projected shortfalls for Medicaid. So what we set about to do was to try to create a patient-centered delivery system that rewarded valuable outcomes. The objectives were pretty much the CMS triple aim: to improve the health of the population, to enhance the patient experience, to engage patients to take an active role in their care. We also wanted to reward providers for high quality, efficient care, and to try to reduce or control the cost of healthcare. And how it was going to be done, well, on the left side there you see patient-centered medical homes. That is basically population management. How do we go about creating an infrastructure and an incentive program for providers to focus more on managing populations as opposed to treating illnesses. To support that, there are episode-based payment incentives out in the market today that work to support the population managers, and we'll talk about that a little bit more later. 4 aspects of the broader program was we had to get better payment and reporting. We are now providing utilization reporting differently and I think more effectively than we ever have. Workforce development. The Arkansas Center for Health Improvement did a statewide study, really an inventory of the assets in the delivery system so that we could understand how those were being used and how they might be more effectively used in the future. Health information technology, the health information exchange, that everyone I think is kind of disappointed with the development of that, because we do really need an exchange of information so that all healthcare providers can look at the patient from a total care perspective, and then to make sure that there's access in the program. Also, when we started this discussion, we talked about the fact that as large as the Medicaid program was, as large as the Medicare program is, as large as market share as Blue Cross had, none of us represented enough volume in a provider's practice to make it sensible for them to change processes and cultures to a more patient-centered, outcomes-based business model. But we also thought probably any 2 of the 3 could. And so we began to work very closely with Medicaid and made sure that all of the initiatives that we put together were aligned as far as especially the expectations and measures for the delivery system. It is not very productive for different payers to have very different expectations, so that when a patient shows up at a doctor's office, they have to worry a lot about what kind of coverage that patient has to figure out how to treat that patient effectively and to do the best by them with their benefits so that they have the least out of pocket and to do the right thing. So as we aligned very closely with Medicaid, we set about the work to make sure that things were consistent for as much of the population as we could. And I can tell you that Medicare was sitting with us through most of those meetings. Medicare has a little bit more difficulty aligning with this because it literally takes an act of Congress for Medicare to be able to align on these things. Through the Innovation Center, they're working very hard, and I think we're very close to getting Medicare alignment, and that's going to be really important, because then I think you have about 90 or 95% of the payment volume behind a consistent methodology, and I think then we'll be able to make some significant progress. We also understood that, we needed to invite all of the payers into the system. So we invited all of our competitors, Qual Choice, United Healthcare, to the table to try to create consistency around as much of the payment as we could. Qual Choice came, United came initially, and over time decided that that the market maybe wasn't big enough for them to expend the resources, but Qual Choice continues to be at the table to create that kind of consistency. The discussion was, there are a few things that Arkansas could do to address the cost problem. You see the 4 at the bottom. Just cut payments for fee-for-service, pass growing costs on to consumers through higher deductibles or higher out-of-pocket, or for Medicaid, higher taxes for the community. Intensifying payer intervention, or Mother May I, those physicians in this room probably just love our high-tech radiology pre-authorization process. There could be even more of that. Or just quit covering people or quit covering things. All of those 4 at the bottom, we all agreed were suboptimal, and so we set about trying to transition the payment system to reward value in patient health outcomes. At the core of this, and we all knew at the core of this, there had to be quality initiatives. It couldn't just be about the money. This would never be socially acceptable if it was just about the money, and it's not the right thing to be just about the money. So in all of these initiatives, if there are financial incentives for providers to do population health or episodes of care or anything like that, there are quality requirements that a provider has to meet And if he otherwise would earn a financial incentive but didn't meet his quality measures, those cost incentives aren't available to that particular provider. There are some that are directly tied to financial incentives, and then there are others that we are using to track because we couldn't come to consensus on those number 2 metrics. We thought they were pretty important, but maybe not important enough at that time to tie to payment, and so we said we're still going to track those. At some point we may tie them to payment, but for right now let's just go ahead and track them and report on those. Then the work began. I can't tell you how many miles we drove in the car. Back then, the Medicaid director was a guy by the name of Andy Allison, very sharp guy. Andy and I and John Seelig and Mike Stock from Qual Choice and a lot of people drove to a lot of exotic places in the state of Arkansas to have town hall meetings to try to get as much input from various stakeholders as possible. So, you know, I suspect that we had direct access to maybe 10 or 15% of the stakeholders, but, you know, the issue was everyone had an opportunity if they took the time to do it. If only 10 to 15% took the time to do it, you know, we appreciated their input. But for others to stand by and throw rotten tomatoes at us when they had the opportunity for input, that was something that we weren't really willing to accept because everyone had a chance. So let's talk about transformative compensation for transformative thinking. Many people, when you introduce the concept of a patient-centered medical home, have no earthly idea what you're talking about. That's getting better. But one of the ways that I guess best resonates with the people that I talk to about what is the difference between a business model of a primary care practice before this conversation and after this conversation, it's kind of like this. When a primary care physician is driving to work in the old system, he thinks to himself, I wonder what kind of services I will need to provide for the people who decide to show up and see me today. Right? A very reactive, provider-centered system. In the new way of doing things under patient-centered medical homes and other population management initiatives, the thinking is, well, I'm pretty confident I've built a model and a plan to make sure that my patients who are in the greatest need of care get the care they need today. And notice it doesn't say, I will provide that care. It says they will get the care that they need today. So I think the assumption is that the primary care physician as a population manager is going to be in a position of management and delegation to make sure those patients get those services, but not necessarily from that doctor themselves. And I think a change from fee-for-service to a different compensation model is going to be required to make that work. Fee-for-service really is an ineffective way to pay primary care physicians if your goal is to have them manage populations. If you want them to manage populations, but you pay them for providing services, what do you think they're going to do? They're going to provide services, right? It's not uncommon for primary care physicians to make 10 to 15% relative to Medicare reimbursement less than the rest of the delivery system. So we're asking for a big lift from the primary care infrastructure, and currently we're paying them less than most everybody else. I think that is something that you really are not going to be able to make work. Non-activity based payment will allow a medical home practice the resources to manage a population. So for those of you who are involved in medical homes, you know that we make payments that we call care coordination fees, which are monthly PMPM payments for each engaged patient that aren't aligned with the provision of services. So that's money to support the infrastructure, to change from volume to value, and actually to cover the cost of things that traditional health insurance doesn't pay for, like telephone calls or emails or different things like that. But really, I think that the future success of medical homes and really all providers is going to be whether they can create a stream of revenue that's not directly tied to resource consumption. That will allow what I what I call a pool of value to be accessed by the delivery system that hopefully will free up innovation to help treat patients better, differently. Right now, payers, health insurance companies, public programs have been put in a position of having to distribute the healthcare dollar by default. And it's really because we're the only ones that have the information and are capable to do that. We have the information from all the various providers that put us in a position to be able to parse that payment out. Well, we in that default position, I think, appropriately said, well, what is the most acceptable methodology to distribute that healthcare dollar? And what we looked to was public programs, Medicare. And so that was the best foundation. So most of our payments are a function of Medicare. Well, when I go out and talk to the delivery system and we say, well, that's as fair as we could be, a lot of times the comment is, what makes you think that Medicare did it right? Very good question, I think. So how do we free up dollars to the delivery system that would allow them to cover the cost of things in a different way? How do we free up dollars that would let them be innovative? Physicians are pretty smart people. And I think if you freed up some of the innovative juices in them, you would find out that they have the ability to create better ways of treating things if they weren't limited by coverage policy, by insurance companies or fee schedules or whatever it was. So that really is the basis of payment transformation, moving from a transactional-based system really to an outcomes-based system. And as that happens, what's got to happen is fee-for-service margins will necessarily be compressed. How do you get a physician to come to the table who's making $750,000 a year under fee-for-service to get interested in this discussion? Very difficult to do that. I think there has to be a template, there has to be a story to be told about what it means to move from volume to value, how long it's going to take, and what it's going to look like. And I think you'll begin to see these things. One of the bullets there says keep a close watch on MACRA. Does anybody know what MACRA is? Well, MACRA is the government's replacement for something called the sustainable growth rate in Medicare. Several years ago, CMS said, if medical inflation is higher than general inflation, we are going to reduce physicians' reimbursement by the difference. Well, that went along 7 or 8 years, and about every Christmas, Congress came up with something called the doc fix. And the doc fix basically said, well, we're really not going to lower them and we're going to increase them a little bit. And the difference between what was supposed to happen in the sustainable growth rate and what actually did happen was about a 21 or 22% reduction in Medicare physician fees that never happened. Well, that's too much to bite off, and so they finally said scrap it, but we're going to put MACRA in its place. MACRA isn't fully developed yet, but directionally what MACRA says is Medicare is going to freeze or even in some cases reduce unit price reimbursement for its services under traditional fee-for-service. But they are going to allow alternatives for providers who get into alternative incentive systems to actually make more than they did in the past. So keep in mind, anything that Medicare has ever done in this regard has become the industry standard. If you'll remember back in the 80s when they put DRGs in place, it wasn't too long before the whole industry started paying hospitals on a DRG basis. When they went to resource-based relative value for physician reimbursement, it wasn't too long before that was the market standard. Look out for MACRA, it's going to create a new market standard, and if we can begin to move towards value-based payment in advance of the implementation of MACRA, I think we're all going to be better off. At the end of the day, the most successful business models will be those that are able to access a new pool of value that will be created by value-based compensation systems. Fee-for-service reimbursement may cover cost for efficient providers. It's certainly not going to represent profit margins that allow lifestyles to continue to be like they are today. So the burning platform for that provider who may be making $750,000 a year this year is that in 5 years that may be worth half that. So pay attention to market signals. Guiding principles that we all used is we wanted to reward high quality, efficient delivery of care and promote fairness by considering patient access. We wanted to make sure that this was workable and doable. A lot of the town hall meetings that we had allowed stakeholders to give input, and we actually made some good changes as a result of that input. It's caused us to have better relationships among stakeholders than we've ever had in this state. Every month I go to a meeting at the Hospital Association boardroom where the Hospital Association is there, the Medical Society, the Pharmacy Association, the Medicaid, the commercial payers, CMS is in there most of the time. 5 years ago, folks, if we'd all been in the same room, somebody gets a bloody nose. It doesn't happen anymore because we talk about relevant things. We talk about things objectively. Yes, we all get our feelings hurt from time to time, but we get over it and we make the changes that we're going to need to make it all work. Acknowledge poor performance is a reality and it should not be rewarded. Yes, poor performance is a reality. Protect quality and access by setting a gain sharing limit. So what you'll see in some of these things is, yeah, we're going to share savings, but we're going to create, a limit on that so, you're not going to get additional savings if you're going so low that you might be withholding services and causing a quality problem. And then sustaining thresholds. No more of this ratcheting down from year to year where the first year it might be reasonable for you to make an incentive on this, but then over time there's no way that you will. Talking about episodes a little bit, I know this isn't the focus of it, but episodes are important to population management because it begins to give population managers an idea of the variation that exists for certain services that they might refer their patients for. The first 5 that we did were hip and knee, perinatal, upper respiratory infections, congestive heart failure. Medicaid did ADHD. You can tell from this slide there is one particular physician in a position to be able to benefit or be at risk for their performance under an episode. I would make a point here that there are some laws and policies that are in place that made sense in the old system that don't make sense in this new system. What we would like to see is like an orthopedic surgeon who does knee replacements be able to earn an incentive, but then be able to share that incentive with his physical therapy partner or with his anesthesiology partner or whoever he wanted to share it with, because it really is team-based care and that one provider should be able to share the rewards if he believes that's the right thing to do. Right now, anti-kickback and START provisions, policies and laws are an impediment to do that, and I think we all need to get together and talk about policy to make sure that our rules and regulations don't hinder us from making the progress that we should. This slide depicts what we saw at the beginning when we looked at an episode of care. Each of those columns represents a physician who delivers an episode of care, whether it be delivering a baby or replacing a knee. And it was not uncommon for us to see this kind of variation for very similar outcomes for very similar patients. Providers were really unaware that this variation existed. Variation can exist because care plans are different. Variations can exist, and I'm guilty as charged for this. In the commercial population, we negotiate reimbursement for inpatient facility. They're different. We need to quit that. But some providers were delivering services at a facility that was paid more than the market average, which caused their cost to be higher. But the issue is, when we started to talk to large employers about this, they would say, if this kind of variation existed in any other part of my business, I would squash it tomorrow. How can you let this happen? So the idea behind episodes is to identify variation that exists, have meaningful discussions about the justification for that variation, and if there is no justification, to eliminate it. The idea is to try to get a shift in the curve from the light blue to the dark blue. And then what happens is, as it all shakes out, the green area is for those costs in the commendable range. There's shared savings for the provider. Between acceptable and commendable, the fee-for-service stands, and above the acceptable level, the provider would owe back a portion of the excess cost. It's not a prospective bundle. It doesn't blow up the world. It continues the fee-for-service cash flow, But it works the same way as an episode. It's just a retrospectively reconciled episode. What does it mean for each of the principal accountable providers? Well, there can be many winners. Everybody can get below that commendable line. We just need to find a way for them to do it. It's not a situation where we set a target after the utilization has occurred and we guarantee that 15% of the people are going to be losers. No, that's not the case at all. We want everyone to be in the commendable range in shared savings, because what that does, for historically, if insurance companies were able to hold down costs, we would keep something that we used to call underwriting gains. The Affordable Care Act changed our business model. They put in something called minimum medical loss ratios, so that if we don't pay at least 85% of the dollar out for a large group, if we only pay 75%, that other 5% is supposed to be rebated back to premium paying policyholders. Probably not a bad thing. They probably wouldn't mind getting a check for $42 in the mail. They probably wouldn't know why. They'd probably get mad at us for charging them too much in the first place. They would go out and spend it on something, maybe something that's not good for their health, who knows. But my guess is it wouldn't change their behaviors. What if we used that money to reinvest in the delivery system to reward the people that actually created that efficiency? And that's the whole idea behind this. First year review, and these numbers aren't earth-shattering, but I will tell you they're meaningful, because the transparency involved in this, I think, was probably as important as the financial incentives. Doctors are competitive people, and they don't like to be seen as being below average, because frankly, I've never met one that believes they are. So in the first year, the settlements on Wave 1 episodes, we gained share at $400,000. We lost share at $169,000. Second year, you can see those go up. But more importantly, we're seeing some program wins in compliance. You can read those there, but one anecdotal story that I've got is, the compliance with ACOG guidelines significantly increased for perinatal services. And the story that we got at the beginning when talking to obstetricians was, you don't need to waste your time in measuring my performance to ACOG guidelines, because I comply with them 100%. Well, when the reports came out, it showed that they weren't complying with those 100%. And some of the questions, some of the conversations was, well, you're not doing your HIV screenings on some of your population. The answer was, well, why would I do HIV screenings on this part of my population? Because I go to church with them. Maybe I need to start going to your church if it prevents HIV. We've seen significant improvement in compliance with quality standards. It's moving the needle in the right direction. Reporting is better than it's ever been. And it's interesting that the distribution of those reports is consistent. Everyone agreed to use the Advanced Health Information Network portal that 95% of providers have on their desktop. It's a portal that is provided at no cost by Blue Cross. Even our competitors and Medicaid said, we will go ahead and send you reports because it's the best way to get them out there. So there's one source of getting reports, and they are all formatted almost exactly the same way. This just talks about the instructions on the reports. This particular report shows that if there's a provider that does an episode, each of these different categories are within that episode, and how many of those providers use a specific service in an episode, and then if they do, what is their cost compared to the average. Give someone a benchmark. It's very easy to get in a rut if you're out there practicing in a 2 or 3 man group, not to know if there's a better way to do things. It's a way that works for you, but is somebody doing it in a way that creates more value? And then they get reports on each individual patient showing the spend in all those categories. So I'm just here to tell you that we are ahead of the game here. I'm also here to tell you that we shouldn't be complacent about that, because the world is changing. The people in that room yesterday were very engaged in how we spend money better. And if we can, I'm not saying that we need to take money out of the healthcare system. What I'm saying is that we can't continue to have increases in the cost of healthcare outpace the growth of the general economy. And the way to do that is not to pay for individual services, it's to pay for the outcomes and create incentives that aren't activity-based. So thank you very much.
Always exciting to hear from the largest insurance carrier in the state. We appreciate their support and the information they bring to the stage. We're a little ahead of schedule, and so I think at this point what we're going to do is go ahead and move forward with our panel discussion. And so if we can go ahead and have our panelists come to the stage right now, and we'll get the lights up here for them. We'll go ahead and move on to that. Keep us ahead of the game a little bit. This is a unique opportunity for you to ask those tough questions to the individuals on the stage here. Dr. Osley, I think there's a seat for you. Yes, ma'am. I believe there's You can generate questions as well. Yes, ma'am. We'll have microphones on either side of the aisles so that we can make sure that everyone clearly hears the questions being asked. Again, this is a unique opportunity for the audience to participate and really ask questions of a group of experts on population health and specifically related to the state of Arkansas.
You intimidated our audience.
It's kind of like my college classroom.
Yeah, really, exactly. Everybody's in the, we're either in class or we're at a funeral. Everybody's in the Yes, Dr. Summer?
For the Blue Cross folks, your quality initiatives, where are those coming from? What's the foundation of the quality? And then do you have some sense of the cost of implementation to introduce those quality principles into practice?
The quality measures that we have in the episodes of care and really in the medical homes have largely been built by stakeholders in our state, leaders in the areas of their work that come and talk to us about what makes sense. Where that's going to go in the future is probably going to be determined a lot by the federal government. You know that they came out with core quality measures a couple of weeks ago, and what I believe is going to happen is that, like for Medicare Advantage programs and for the exchange programs, the success in meeting those core quality measures are going to be determinants for revenue that comes into that pool of value. So what I believe is going to happen is the quality measures have been established locally for now. I think they're going to be more and more influenced in the future by federal quality guidelines. We know that it's cumbersome for the delivery system to keep up with those. In our episodes of care in our medical homes so far, we have tried to, as much as we possibly could, track quality measures that were able to be gleaned from the claims transaction so that the physicians didn't have to manually load a lot of quality measures in through the portal. They still have to do some of those things, but it's always going to be our intent to look at how can we automate and make it easy for the providers to report on their quality measures.
Before I ask my question, I just would make a comment on his point there. And I would really encourage us to think of some other term rather than quality, because what providers and a lot of patients think of as quality is not what is being measured as quality. These are statistical measures, they're bureaucratic measures, and they're not what providers and patients think of as quality medical care. And that sort of provides a built-in disconnect and also makes it a little difficult to get providers on board to measure their quality when if they get penalized because they can't send a secure message to their referral people because their other referral people don't have the capacity to do that. And so I get penalized because I have to fax them. And that's not a quality medical issue for a provider. So I think we have some basic communication things to do to get some of the people on board, and that blocks that from the very beginning. So we still have some communications.
I agree with that.
The thing that I would like to just throw out is that the old system of fee-for-service was manageable from the provider side because then you could control your business, you could control your practice, you could control your overhead by deciding what you're going to do and how much you're going to do. And you had pretty much control of what your income was going to be. If you wanted to make more money, you worked harder. With some of these other things, you don't have much control. And that is the thing that I find in our area that prevents most providers from participating. They're not sure how they're going to be able to manage in that if they switch over. Our practice, we made a conscious decision that we were going to do two things. We were going to still take care of our patients, but we were going to try to be on the front end of every electronic and program innovation that came along instead of being on the back end. And so we participated in all these programs you talk about and have from the beginning, but the only way we've been able to survive and do that is because of some of the built-in incentives that you talked about. And to participate, for instance, just as a practical point, we have 5 physicians, 2 mid-levels, and 35 support employees. That was umpteen years ago. To participate in all these programs, we still have the same number of providers, but now we're up to 50 support staff to be able to do all this stuff that was required. And so, what does that say about cost? Well, our cost is going to, the only way we can do it is because you're paying incentives. And if you take the incentives away and we can't pay for that, then we can't do it because we can't sustain that much increase in our cost to provide what the programs require. So just wanted to kind of throw that out we can do it if we have enough people and enough equipment, but we can't take it out of our skin and stay in business.
There's a great almost dichotomy here. The first lecture we had emphasizes the fact that there is not a one-size-fits-all approach, and we need to look at individual populations for population health. And we just had a very recent lecture from Blue Cross Blue Shield, essentially encouraging everyone to get into this same line. Now, how much of a barrier is that going to be to the implementation of population-based health care when we're all trying to get to the same goal?
Well, I'll take an initial shot at that. I'm not necessarily sure that our message is that it's one size fits all. We're saying that what we've got to do is try to move away from the focus on delivering service and health-related, or I'm trying to get the appropriate wording here is care-related activities to looking at managing whole health. Now, you'll have to do that differently with different populations. But the idea is that the physician would be able to be, and the delivery system would have a pool of money that's there available, rather than it being fee-for-service. based on transactions being a pool of money that's available there. And then within that structure, they're the ones that are best able to understand how to reach particular populations. And then if ultimately, if you get to the direction I think that Steve's talking about, is that you would have the opportunity to recognize for this part of the population, I need to have a heavy emphasis on behavioral health and social welfare activities and so forth. And so you could move resources to that for that segment of the population. For another segment of the population, it may only be medical services that you really need to focus on, and so you can focus your activities on there, but you have different levels of providers and different levels of services that you're able to put in your market basket of how you deliver care and manage the overall health of the population rather than managing the health of an individual in a reactive type of basis. So that's kind of, in my mind, that's the message that we're saying is financially there may be a new model about how you get paid, but that provides you the opportunity to really try to tailor it to specific populations to where you can really get them engaged in their own health and make some major changes in their life. So,
can I add to that? So the value volume shift in delivering health care, I think, is in the financing of health care is really going to be a disruptor. And in our local community, we've been at it for probably 5+ years now, just under 5 years, I guess, with looking at birth outcomes for high-risk Medicaid-eligible enrollees. And we've arrived at this sentence, and I think it speaks to this issue. If you're paying for the outcome, we're rather agnostic about how you get there. And so right now, traditional service delivery, payment is linked between a diagnosis, some idea of medical necessity, some idea of a CPT code in a context, and there's a bureaucratic structure. And we've all looked at explanation of benefits. They either deny or don't pay, or you don't have your 5th digit, or you don't have your this, or you don't have your that. And outcome-based payment, well, there is a transition stretch where these quality metrics are being layered in to define what the outcome is we're desiring. It really disrupts that whole equation, and by disrupting it, it allows into the delivery system people who don't work under the I can give a diagnosis, I can deliver a service. And as a small community that's had a small cohesive group of people in this field, I can tell you 5 years in, you were saying I don't know how long it's going to take for the cost to shift, the idea to shift. Is it so dissonant with how we think about service delivery right now? We just keep going rather agnostic about how you get there. And we then tell absurd examples. So like one of our incentive-based outcome payments is long-acting contraceptive. And it's tied around preventing unwanted teenage pregnancies and timing and spacing between pregnancies. And an agnostic, this is absurd, but I'll just toss it out there because we've used this example locally. An agnostic way of getting there would be for a school district to decide their girls' sports teams, no one can be on a sports team unless they have a long-acting contraceptive. And then everybody gets long-acting contraceptive so they can play sports. And they're mortified. This is not a quote to the Blue Cross Blue Shield people. but
I could even give you an example.
You could do more mortified. Yeah. And so what you're really talking about is bringing to bear on health outcomes non-traditional health care. And honestly, the insurance, somebody asked earlier, you did, who pays?
Yes.
The insurance companies are interested in supporting that level of innovation because they have full risk for the costs associated with caring for people whose outcomes aren't moving in the right direction. And so it's a very, very interesting time. And if the partnerships are in place, and particularly at the local community level, to leverage your community resources towards health outcomes. The payer environment now is, they're all sitting there going, give us an idea, give us an idea. And we'll think about it because it's a value payment. It's for the outcome, not for the process.
Yeah, and I think that's a great point, and it could be that the value of submitting procedure codes and diagnoses and different things like that are not for the purposes of generating revenue. They're going to be for the purposes of determining resource consumption, because it's going to be a determinant of, what the pool of money is that's tied to the defined population, and the services that are provided to that defined population are going to be delivered, and the resources that are used to deliver those services are actually, a credit against that pool of dollars. So the conversation could change very significantly to one where the provision of service is not important to me because it generates revenue for my business model. The provision of services is important to me because it is a cost against a finite pool of value.
And to kind of bring this whole discussion home, under the umbrella of medical education readiness, I'm sure all of you realize in our health professional education systems, none of this kind of discussion goes on. And even more so, we're involved in rapid change all over the place. Every time we change, and particularly when we come up with an innovative, proactive or reactive model, we put another name on it. And so we create a language of change that, quite frankly, is not well communicated between the groups, which we heard a little bit earlier. But it is our goal with this particular medical school that we begin early exposing our students to this whole issue of the system of healthcare and the changes that are involving, because as I tell students all the time, we're not educating students to practice medicine today, we're educating them to practice medicine in 5-10 years from now. And medicine's not going to look the same, and the tensions we're feeling now will probably disappear with new tensions coming on board. But we've got to have a workforce that recognizes the change as a part of the system and that can accommodate and understand that language as it evolves. And so that's kind of what we're hoping, that our teaching faculty, as part of the overall system of training in the community, will understand this is our goal, our objective for our students as they go through the system. That they will also not just know all pathology and normals and abnormals, but also understand to be able to impact these pathologies, to be able to impact population medicine. They must understand the language, the system, and the evolution that's going on.
I have a question I think is more directed towards our Blue Cross representatives, but excuse me. Our residency program, we're certainly involved in population health efforts, and we learn something new every day in that regard. But one of the things that we're starting to see here in our community, and I'm sure it's happening in other communities too, but when we take an active role trying to reach out to these patients that are high utilizers of the emergency room or the hospital, if we find that there are some folks that don't respond to our outreach, whether it be with a health coach or with behavioral health or many different avenues that we try and reach out to them, sometimes those patients get shifted amongst practices because at some point you draw a line and say, okay, I'm not getting anywhere with them, and so I'm going to have to cut ties with them. Is there concern that there's going to be a population of folks out there that have had ties cut with all the practices within a community, and if so, what do you do with those patients?
Well, that is definitely a potential issue that you run into, because even in our own programs, and that was one of the things that as we brought on the Medicaid expansion population came into our commercial marketplace, one of the things that we saw very clearly was a high rate of ER utilization, and so we proactively tried to reach out and work with those individuals. And you run into some, and then that's where it really became clear to us that there were so many behavioral, socioeconomic, other drivers that were there, that's why you've got to figure out some ways to look at what it takes to help somebody be healthy and get engaged. You've got to look at it a lot differently, and we've got to figure out a different way to pay for people doing that, because it's kind of the definition of insanity is keeping on doing what you're doing and expecting to get different results. Because if we don't change that process, so yeah, there will probably be people that are very difficult to deal with, but that's the challenge I think that we all face, and we try to figure out how do we pull community resources together, because from my personal perspective, I always believe there's an underlying cause behind that, and it's just, do we figure out what it is? And you run across that in the Medicaid space a lot, and when you talk to some of our colleagues that work in traditional Medicaid, for example, you find out the reason somebody goes to the ER so many times is they don't, it's during the summer and it's 105 degrees in their house and they don't have air conditioning, and even if they had air conditioning, they don't have the money to pay for their electricity, so you figure out a way to get that service to them, and suddenly they don't go to the ER. Or they go to the ER because they get social contact. And I just remember an anecdotal story about another carrier in another state that was working with a population like that. They got the person a dog, and the dog kept them company. They quit showing up at the ER. So those are the things that I think we never really, we're so busy doing all of the things that we do that we don't get to the level of really knowing what the root cause is and what might be some simple, very low-cost solutions to keeping somebody from being involved in expensive treatments. So,
yeah, our project, we've heard the social in the ER event from families in our region, but part of our care coordination outreach effort for the high risk for poor maternal child health outcomes in our birth project was to do education. Mm-hmm. And you invite people to come to a health education program, and nobody's showing up. What we found out was for many of our families, they had no way of getting photos off of cell phones, and we set up a scrapbooking, bought a printer, invited people in, and they come in gross for scrapbooking, access to a printer, and along the way, nurse navigators lay it in beautifully, little token economy. If you got your smoking cessation content and your how to, care for my new baby content, and so all the education pieces were constructed around an activity people wanted to do.
Yes.
Right.
Not go to school.
Yeah.
Yes.
And it was it was great. Yeah.
That's a great example of thinking about things differently and going back to some basic learning principles. And most all behaviors learned, and you can change the environment around, and if you change the environment, you'll see changes in behavior. And so what you were able to do was identify something that was of value and then pair it, and that'll probably have an impact on behavior over time. But who would approach that from thinking that's a medical issue or a medical care delivery issue? But it really is.
Yeah, and I think it's going to be interesting to watch the evolution of the roles and the responsibilities of the different stakeholders in this, because right now, because the insurance company has held the risk, then they've been responsible for mitigating the risk through not paying for some things or putting benefits in that might not make sense and all that kind of thing. As risk is shared, I think the insurance company's role may be very well to try to help the delivery system succeed as much as they possibly can in the position of risk that they have. And that's a very different business model than we have today.
And, in fact, that's one of the things that we're attempting to do, is to try to be sure that we have a very good understanding of the community resources that are out there available, and then being able to get that information to providers and to our customers, so that we know that we can try to pair them up, and actually even proactively trying to do some of that pairing. And that all ties back into the patient-centered medical home approach, and trying to support that. So.
Just looking at this from several different perspectives, as an educator, as a physician, and administrator, I feel like I have a really unique perspective. Just a couple of things that I seem to have come across multiple times. One of those, as a physician, is that there seems to be a lot of sort of checkbox fatigue in terms of meeting these healthcare sort of goals and everything. And as well, there's multiple providers that don't even have electronic medical records right now. And so I'm wondering how you guys are keeping up with that and ensuring that these providers that are out there providing care to some of our sickest people in the rural communities don't even have, ability to have access to electronic health records, and you're tracking all of this data through that avenue. So that's one potential problem that I see. The problem that I see from an administrative standpoint is that there is really a small core group of physicians that really understand what it means to provide quality care, to provide population health, and are really in tune to that. And so I have found it a challenge to kind of bring people on that sort of bandwagon and board and understand the importance of really taking care of the whole patient. For example, explaining to an orthopedic physician that you can't just cut on a knee, you have to, think about the heart, lungs, and everything else, because you can't cut on a dead. So there are things like that happen in conversations that I've had. And then the final thing, in terms of being an educator, I feel like because there's such a small group of core physicians that really understand, this population health in our area, we're going to have to really try to teach and develop a core group of individuals to bring these medical students to where they need to be. And I think that will be one of the biggest challenges that we have here. So.
I think with regard to the checkbox fatigue, and I don't know, Sebastian, if you want to weigh in on this, as data really penetrates more deeply and deeply into our daily lives, the accuracy of data really needs to be attended to, and in thinking about what, curriculum issues really lie here. People check boxes to fly through the EHR screen, and then information gets used to make decisions, and decisions are made, and then you show up and they say, oh yeah, I'm seeing all my 21 to 56 day postpartum visits, and you pull out a run chart that says not really, yeah, and some of that is just data entry.
Yeah, that's a real good point, because we have so many different EHR programs and hardly any of them talk to each other. And that's a whole separate conference, isn't it, I think?
Definitely so.
Just another observation in all the things we've talked about here is that we haven't really addressed patient responsibility, and that's, we can do all of these things, and if we don't have, if our diabetic patients say that I'm going to go sit on my couch, eat potato chips and watch TV, and if you want my blood sugar to be better, give me more insulin, we can do all these things and we still have a problem. And I think the person was sort of alluding to that a little bit back there about these problem patients. So again, I'm going to participate in this. We're participating in these programs. We're doing the best we can to implement and make them better and utilize them. But so far, we haven't found a good way that's uniformly efficient and effective in drawing in the patient responsibility to the level it needs to be. And I hope you guys are coming up with some ideas that we can use about that, because that's still besides all these other issues that are challenging, that's still our greatest
Yeah.
challenge as providers. And the other thing is that, really what you're talking about here with this population thing is a complete cultural shift. You're talking about patient care, and historically up to now it's been taking care of the patient and the populational benefit idea. And now we're talking about taking care of the population. We're going to do herd management really good, and the individual patients are going to benefit. And that is a complete cultural sea change in our country and in our communities. And I hadn't really thought about that till today, and we got to figure out a way to help people get over that hump.
We've used the word team way less frequently than I thought we would have by this point of the day. But I think along with that shift is the idea that it's not just the physician. And so that the responsibility for the population's health is not isolated or just on the shoulders of the physician, but there's an entire system and a community that has to contribute. Physicians, because historically you've been the quarterback of the health agenda, are now needing to be raised and acculturated into an environment where they take a different role, still the doc for some of their patients, but quarterbacks of teams and ambassadors of community relationships in order to accomplish the larger goal of population health.
Yeah, I also wanted to say that it seems like this is a silent issue here, but I think from a population health perspective, we also need to address the wellness of the workforce. And so as we talk about all this impending change, I think it's fair to say change is coming whether we like it or not. But regardless, in terms of educating future physicians, we need to be concerned about their well-being. And in terms of population health, we need to address some of the strains that are part of being a primary care physician, a pharmacist who has to repeatedly deal with people looking to, get opioids from some excuse. I'm not saying, I don't want to make it a physicians versus everyone else thing. I think we also need to realize that population health needs to address the wellness long-term of our physician and other healthcare provider workforce. So thank you for that comment.
Yeah, and I'd like to go back to the comment about the patient engagement and so forth. That's one of the things that we recognize as critically important. We know that's one of the huge challenges that the medical community faces, is really getting their patients engaged and being compliant. And so but what we're looking at is technology creates some opportunities for us as well in terms of trying to be more connected with are insured and helping them understand when they need to have preventive services, when they're being compliant or not being compliant with their meds and so forth. And to the extent that we can be not as something that's in between the patient and the provider, but be a communications channel. That's what we want to be. We want to be an enabler, because for our opinion is for this to work is you have to have engaged physicians and caregivers, and you've got to have engaged patients, and you have to have a literate population that has health literacy. And so we have several different activities that we're trying to work on to try to get these things aligned over time. But this is a marathon, not a sprint. And going back to the earlier comment about a few leaders, you need a few world-class leaders to lead the pack. And one of the things that happens is it draws the other people that want to be part of that marathon along at a faster pace. And so that's something that we've got to do. So there are a lot of systemic things that have to be operated on at the same time to get us where we need to be. But we do have to go about it pretty quickly.
Steve, it might be helpful for folks to hear your perspective about what the self-funded impact, our self-funded customers, and that volume of business might have on some of these issues we're talking about.
Yeah, that's a good point, and we have some of the largest employers in our state. I heard one talk last week at the National Business Group on Health about the fact that they are not naive enough to know what the right answer to this is, but they do know that the right answer to this is not what we're doing today. The fact is we have to continue to try different things. This particular employer is sending people off to different parts of the country to get certain procedures outside of the patient's local neighborhood or where they would generally go in their local delivery system. They're not doing that because it's cheaper where they're sending them. They're doing it because they believe that the places that they're sending their employees for evaluation result in about a third of them receiving an alternative treatment that's not as invasive. So, like they said, they don't know what's the right thing, but they are certainly frustrated enough to try a lot of different things. So I think that represents an opportunity for us to create innovative value that will include our input before the market solves the problem and doesn't ask what we think about their solution, and basically takes the care outside our communities. And so yes, it's hard. This isn't for sissies. It's a heavy lift. But I think the alternative to doing something different is worse than potentially failing on a thing or two, but ending up in a better place than we are.
I also had a question about for the Arkansas Blue Cross Blue Shield gentleman. In your methodology as far as going out and speaking with stakeholders and getting the quality metrics, have you had a chance to speak with other peer states, your peers, about what they find unique about the process and the findings that you did in that entire process?
Yeah, as a matter of fact, the state of Tennessee is doing something very similar to what we've done. It's a different world over in Tennessee because they have managed Medicaid for their entire state, and so they were able to impose on their managed Medicaid vendors, the responsibility of having to do this. If you listen to Governor Kasich in his health care reform talks in his campaign, Ohio is doing a lot of the same things that we are doing. Now, there are some places in the country that are doing things very differently because their environment is very different. If you look at Minnesota, where they have like Health Partners and Mayo Clinic, they have significant process and financial integration, so they're able to do more risk sharing in a different way than we're doing it. I guess that would tell you that the best solution to this is not going to be a one-size-fits-all. That's why I am concerned about a single-payer healthcare system for this country, because I don't think one single system can be the best value for every single community across the country. But I'm afraid if we don't do something different, that will be the default position, and we all will have regretted not doing a little bit more work to try to make it better ourselves.
Certainly excellent discussion. We appreciate our panelists. I'm going to try to, my job partly is to keep everybody on time. So at this point, we're going to adjourn to lunch, which is in the Spring River Room. As you go out the back entrance here, you'll go to your left. There should be some NYIT badged individuals that can help move you in the right direction. We do have a lunch presentation that I think you will all enjoy as well, and we'll speak more to that once we get into that room and start. But if you don't mind, give a round of applause, please, to our panelists for their time and their expertise.
Interesting world that we live in. Well, thank you. Appreciate it. 20% plus of our
Thanks a lot. Great perspective.
It's an interesting conversation. I think we all need to be humble enough to know that we're not going to get it right. We just need to continue to try to get it better.
Architect.
Yeah, then being directed on that.
I do a lot of pregnant women. 57th day, that's it.
Until the
something
next.
that navigates them over to the next.
Yeah.
one. So I think
Well, but see, that was one of those things that I think ended up being the old minds of people didn't even think about. Because as this was being developed, people didn't get into that level of thinking about it. But what's happened is when you start getting an argument about whether or not you continue the program,